Prof's book. Thank you very much. So today,
sorry,
Dr.
Dr.
Yes,
Dr. Okay, so I'll
quickly move on and start. I believe that we are all having a lovely new week. And today we're going to start with the curriculum topic by Dr. Odonye. I think that is pericardial disease. So we are starting by.
Give me a few minutes.
Wait.
I'm trying to close so many things on the desktop so I could bring up the slide. A few minutes, please.
All right, sir. We have the presence of one of the board of the group, Dr. Kweke. You're welcome, sir. So let's just sit back while we wait for Dr. Odoye to start. Thank you all.
Let me see. Screen. Yeah. So is the screen visible to everyone, please? Can I get a response?
Yes, sir. Thank you so much. You can see the screen. Thank you. You can start, sir.
Okay. Good evening to the house. This evening, I will actually do a presentation on pericardial disease, and then under this following an outline. So starting with the pericardium, and starting with the anatomy of the pericardium, it has 3 layers. We have the viscera, the pericardia, and the pericardium. And the third layer is the outer fibrous layer. So for the visceral pericardium, it's a monolayer of mesothelial cells, which also has collagen and then elastic fibers, which are adherent to the epicardiac surface of the heart. And so the visceral pericardium reflects when it gets to the origin of the great vessels, where it continues and forms the inner layer of the pericardium. And the pericardium is a fibrous layer, which is approximately 2 millimeters thick in human beings. And it's said to be largely acellular. Fibrous layer, okay, which I'll show you a few pictures much later. So the space between the viscera and the pericardium forms the pericardiac space, which usually contains about 20 to 50 mils of 20 to 50 mils of serous fluid. Okay, this is just a picture. The picture on the right. Can we see the cursor, please? Or I should change to a pointer. I don't know which one will be appropriate. Okay. Please, can I get a response? Okay. Yeah. Okay. So. Okay. So, so this is just a cut. Okay, like the 2 halves as it were, kind of, and you can appreciate the viscera layer here. It's closely. I just sent to the epicardiac part of the heart, and then we also have the viscera. So cutting it down, we have the innermost part, the endocardium, the middle one, the myocardium, and then we have the viscera overlying the epicardium, and then we have the so the viscera part overlying the epicardial part of the heart, and also the pericardia. So I have a picture much later to show the outer fibrous layer, which is not really obvious here. Okay, so the pericardium has ligamentous attachment to the diaphragm, the sternum, and the costal cartilage, and this helps to keep the heart in position within the thoracic cavity. And then, so the pericardium also contains some non-cardiovascular structures which are associated with the pericardium and the phrenic nerve, and which is enveloped in the parietal pericardium. Okay, so talking about the physiology of the pericardium, it has a restraining effect on the cardiac volume, and then this reflects the mechanical property of the tissue. So the parietal pericardium has a tensile strength, which can be compared to that of a rubber. And so at low stress, it's elastic, but as it stretches, the tissue gets to a point, the pericardium gets to a point where it abruptly becomes stiff and resistant to further stretch. So the pressure volume relationship of the pericardial space, a sac, parallels the property of isolated parietal pericardial tissue. So talking about the function, it's like a covering for the heart, so it provides barrier to infection, and also the lubrication between the viscera and the parietal layer of the pericardium provides lubrication with the fluid in there. And the pericardium is also innervated with mechanoreceptors, chemoreceptors, phrenic nerves, like we said earlier on, and this helps to mediate transmission of pericardiac pain. And the pericardium also secretes prostaglandin and the related substances, which are important in modulating neural traffic. It explains why when the patient has an inflammation of the pericardium, some of them will come down with pain, and then some other cytokines that are released will also explain why they tend to have a fever, basically. So now to acute pericarditis. Acute pericarditis is an inflammation of the pericardium, which is characterized by pericardial chest pain, a frictional rub, and then serial ECG changes. And then most of the time, it's said to be idiopathic, and then most of the idiopathic causes are presumed to be due to be viral in origin. But routine testing for these specific viruses are not usually done routinely due to issues of cost, and a number of times they also start to have a low yield, and then may not really impact on the management of the patient, basically. So for the epidemiology, the incidence of acute pericarditis is difficult to quantify because it may be underdiagnosed. A number of people may not even come around to the hospital. They might be able to bear the pain in some instances. So at autopsy, the frequency is said to be approximately 1%. And the pericarditis is common in the emergency department, where it accounts for about 5% of patients with non-ischemic chest pain. So the fraction of all acute cases accounting for idiopathic pericarditis, as opposed to those with specific cause identified, is also uncertain. And the presentation is influenced by the demographic and variation in the viral infection, usually. So these are just quite a number of etiology that can actually cause pericarditis. It's said to be idiopathic most of the time, and it could be infectious. So for infectious, we have varieties there. It could be viral, could be bacteria, HIV associated, it could be fungal, protozoan. It could also be due to inflammatory conditions, which we could find in patients who have connective tissue disease, systemic lupus, rheumatoid arthritis. It could be drug-induced, procainamide, hydrolazine, isoniazid, cyclosporine, and it could also be due to a number of other miscellaneous causes like sarcoidosis, chest strokes. And after myocardial infarction, 1 to 6 weeks later, could also have the Dressler syndrome. It can be due to cancer, hemoperitoneum, where there's trauma, and then a number of other causes, just to save our time. So for the classification, they classified into acute pericarditis, subacute, and chronic pericarditis. So for acute pericarditis, less than 6 weeks, and then it could be stratified into whether it's a fibrinosus or it's FUC, basically. And the fibrinosus type are usually dry, and the FUC one will actually produce something fluid as it were. Okay, then the subacute pericarditis within 6 weeks to 6 months, and then also be subdivided into FUC constrictive or constrictive. And for chronic pericarditis, for more than 6 months, it can also be subdivided, stratified into, broken down into whether it is constrictive FUC or adhesive. Okay, So looking at the pathogenesis, basically, this diagram is just to explain what happens. So, okay, this is, I hope you can see the cursor. So this is the heart, as it were, so to speak, okay, in front here. So this is crossed line here, okay, represents the viscera part of the pericardium. Then next to it is where we have the puretal part, okay, and then we have the pericardial space in between. Then the outer part is this is the fibrous, outer fibrous part of the pericardium, okay. So depending on what the etiology is, it will definitely cause a form of inflammation. And we're aware that with inflammation, all the features of inflammation, loss of function, redness, and the rest of them, there'll be swelling. And generally with the swelling, we notice the second picture in between, there's much more of the swelling from the parietal and the outer fibrous part of the pericardium. And there's a narrowing here of the pericardial space because of the swelling we have at this other end, okay? So when it gets complicated, it becomes effusive, then there's production of various form of fluid in between. And we can see in this last picture that there's a widening here. Okay, this is the visceral pericardium. Okay, and then the what's it called now, the parietal and the fibrous pushed to the other end. So the space in between seems widening and occupied by fluid. Okay, so when the process of inflammation starts, there's arachidonic acid in the membrane, which is released. And COX also works on that. And when COX works on it, it produces prostaglandin and then troponin A2, which are another cytokines which are important to explaining why the patient will come down with fever, pain, and also worsen that inflammation. And looking at treatment from this point, we will appreciate why a COX inhibitor would be preferred to actually manage this condition. Okay, so still on the pathophysiology, the pericardial physiology includes three main functions. One, it's a mechanical function. So the pericardium promotes cardiac efficiency by limiting acute cardiac dilatation and maintaining ventricular compliance with preservation of the stelling curve and then distribution of hydrostatic force. And the pericardium also creates a closed chamber with subatmospheric pressure. So the membranous function, the pericardium shields the heart by reducing the external friction and also acts as a barrier against infection, as was earlier said. And the ligamentous attachment also helps to keep the heart in position. So in acute pericarditis, the pericardium is the pericardium is actually inflamed and has infiltration of polymuconuclear leukocytes, and there's a pericardial vascularization. Often the pericardium manifests a fibrinous reaction with exudates and then adhesion, and the pericardium may develop a serous or hemorrhagic effusion. And so for those who have granulomatous pericarditis, usually associated with tuberculosis, fungal infection, rheumatoid arthritis, and sarcoidosis. And in the recurrent pericarditis, the immune system appears to play a role in the pathogenesis. And uremic pericarditis could result from inflammation of the viscera and parietal by toxin, the uremic toxin. Okay, so talking about serous pericarditis, there's serous inflammation exudates are characteristically produced by non-infectious inflammation such as rheumatic fever, SLE, scleroderma, and then tumor. And because of that close proximity of the pericardium, as infection in the tissue, an infection in the tissue contagious to the pericardium. So for those who have pleuritis, bacterial pleuritis, because of that close proximity, it may also affect the parietal pericardiac area and cause some form of steroid deficiency, which may progress to frank suppurative reaction. And then looking at it morphologically, the inflammatory reaction in the epicardiac and then pericardial surface with scanty numbers of polymuconuclear leukocytes, lymphocytes, and then macrophages. And the volume of fluid increases from what we talked about, we said 20 to 50. So it could actually increase to 50 to about 200 mils and then slowly accumulate. And so mild inflammatory infiltrates in the epicardiac fat, predominantly lymphocyte, is found in chronic pericarditis. So talking about the fibrinous and the serofibrinous pericarditis, the anatomical form are the most frequent types of pericarditis, and is composed of serous fluid mixed with fibrinous substances. And so the common cause, you have acute myocardial infarction, Dressler syndrome, uremia, chest radiation, SLE, and trauma. So looking at the morphology for the fibrinous pericarditis, the surface is said to be dry with some fine granular roughening, and therefore serofibrinous pericarditis, an increased inflammatory process will induce more of a thick fluid, which appears yellowish and cloudy, which is due to the presence of white blood cells there, the leukocytes and erythrocytes, and fibrin also. Okay, and so the fibrin may be digested with resolution of the exudate, or it may become organized. So development of loud, sorry, just have a little cough. Let me. The development of development of a loud pericarditis. Yeah. Sorry, I have a little cold.
Sorry, sir.
Development of a loud pericardiac frictional rub is the most striking characteristics of fibrinous pericarditis, and then they tend to have pain, systemic reactions, and then signs suggestive of heart failure may also be present. Sorry, the slide is not moving. Let me try. Okay, next. Okay, so I have the purulent or suppurative pericarditis. They denote invasion of the pericardiac space by infective organisms, which may reach the pericardiac cavity by several routes. Okay, sorry, please, a minute. Yeah, so one could have direct extension from neighboring inflammation, such as empyema. So due to that close proximity, it could actually cause pericarditis, and then from empyema of the pleural cavity, patient with lobar pneumonia, intestinal infections, extension of the ring abscess through the myocardium or aortic root in infective endocarditis. So it could also be hematogenous when we have seedling from the blood. It could be lymphatic in origin, and also direct introduction during the cardiotomy. Okay, so immunosuppression predisposes to infection by all these pathways, and the clinical finding in the active phase are essentially the same present in fibrinous pericarditis. So patient could have systemic features like fever, chills, and rigor, and the rest of them. Okay, so for hemorrhagic pericarditis, an exudate composed of blood mixed with fibrinous or suppurative effusion is most commonly caused by malignant neoplastic involvement of the pericardiac space. So hemorrhagic pericarditis can also be found with bacterial infection, with patient who have underlying diastasis and tuberculosis. Okay, can also be found during cardiac surgery, and the clinical significance is similar to that of the spectrum of fibrinous or suppurative pericarditis. So for caseous pericarditis, caesation with the pericardiac space is until proven otherwise tuberculous in origin. A number of times you also have fungal infection, which bring up a similar reaction. So the pericardiac involvement occurs by direct spread from the tuberculous foci within the tracheobronchial nodules. And the caseous pericarditis is rare, but is the most frequent antecedent of a disabling fibrocalcific and chronic constrictive pericarditis. So we also have the chronic or healed pericarditis, which usually is referred to as adhesive mediastinal pericarditis. So this form of pericardial fibrosis may follow a suppurative or caseous pericarditis following cardiac surgery or radiation to the mediastinum. And then the pericardiac sac is obliterated, and then adherence of the external aspects of the pericardium to the surrounding structure, which actually produce some form of restraint on cardiac function. With each systolic contraction, the heart is pulling not just against the pericardium, but also those surrounding structures which is attached to. Okay, so there's also constrictive pericarditis. The heart is it seems to be in a case, as it were, which is dense, fibrous, and or fibrocalcific, and that limits that the diastolic function of the heart and seriously restrict cardiac outputs. Okay, so if the diastolic function is impaired, that means the heart won't be able to suck in more blood. And once it can't suck in enough blood, it might not be able to give out enough output, basically. Okay, so for the morphology, the exudate range from having a thin to creamy pus, and then the serosal surface are reddened, granular, and coated with the exudate. Microscopically, there is an acute inflammatory reaction which can extend to surrounding structures where we have the mediastinal pericarditis, and then organization is usual outcome, but resolution is not so frequent, and then this can actually make the patient to substantively have a constrictive pericarditis. So going to clinical features of constrictive pericarditis. So patients tend to have fever, like I explained initially. When you have the COX working on the arachidonic acid, then you have the prostaglandin, the cytokines that are released. We explain why they have fever. They also tend to have, because of other cytokines that are released, they have myalgia, or they have muscle pain, and they have chest pain, which is relieved by this tripod position and worsened by lying flat. In some instances, some of them may also come down with signs of right heart failure, which you have a pedal edema, raised JVP, amongst other things. Okay. Sorry, the cursor isn't moving. Let me try. Okay. So for the clinical features, chest pain said to be present in about 85 to 90% of cases, and it's usually present in the acute infectious type, and in many of the forms which presume to be related to hypersensitivity or autoimmune issues. So the pain is often absent in slowly developing tuberculous or post-radiation neoplastic or uremic pericarditis. And the pain of acute pericarditis is often severe. It's with left precordial area, and sometimes may be referred to the neck, arm, and left shoulder, which can confuse with a patient who has acute myocardial infarction. And the pain is said to be pleuritic, but sometimes it is a steady constricting pain which radiates to both arms or either of them, basically. So I think we talked about fever. Some of them could have dyspnea, the irritation of the diaphragm. They could also have hiccups. So for the clinical features, still on the clinical examination, so pericardiac rub is found in some of these patients, and it's said to be pathognomic. However, it's found in just about less than 33% of cases. Not every patient will possibly show that pericardial frictional rub, and then exactly said to be found consists of 3 components. So during ventricular systole, then also early diastolic feeling, and then atrial contraction. So ventricular systole, early diastolic feeling, atrial contraction, and the sound, the way it's described in textbook, is said to actually sound like a crunch, like walking on a crunchy snow. Okay, so the rub is usually loudest at the lower sternal border, and the best heard with the patient leaning forward, and it's often dynamic, disappearing and return over short period, and the sensitivity is said not to be high. Okay, for the diagnosis to make assessment of acute pericarditis, there's a ESC guideline. So it could actually be divided into acute, incessant, recurrent, or chronic. So for acute pericarditis, patient can meet 2 of 4 criteria. One is to have a pericarditic chest pain. Could also have pericardiac rub. Please just a minute. Let me get some little water. A pericardiac rub.
Sorry, sir.
And then new widespread ST segment elevation or PR depression. I think we've talked about most of these things while we were treating brown ward a couple of weeks ago. We could also have a pericardiac effusion, which could be new or worsening. So any of the two, and there are also additional things that could also be considered when there's an elevation of a C-reactive CRP, ESR rate, and also the white cell count, and then evidence of pericardiac inflammation by imaging technique, CT and the CMR. So for patients who have incessant pericarditis, it's said to actually patient will have pericarditis for more than 4 to 6 weeks, more than 4, but less than 3 months without remission. So in between 4 to 6 weeks, and but not more than 3 months. Then also said to have recurrent pericarditis after a first documented episode of acute pericarditis, and is symptom-free for intervals of 4 to 6 weeks or even longer than that. Okay, and for those who have chronic pericarditis, the pericarditis must have lasted for more than 3 months. So I think last time we had this discussion, somebody raised a question about non-specific pericarditis. I just thought of just putting it there, but so from what I saw in the literature, they refer to it as a non-specific pericarditis, and it's said to closely resemble cardiac infarction, and but it's said to carry less prognosis, and it's said to be associated with chronic constrictive pericarditis. And for the age group where it is found, it's found within people 30 to 50 years or even older. So they refer to those age range of 30 to 50 and those older as a coronary period of life. I think just to add that, okay. So for the differential diagnosis, at least for pericarditis, we know that when the patient sits up, okay, they feel better. When they lie down, it's worsening, and it can help us to differentiate it for some of these myriad of differential diagnoses, basically. So going to the investigation, the ECG is recommended, it's class 1 recommendation for every patient that is suspected to have acute pericarditis, and the transthoracic echo is also a class 1 recommendation for patient with suspected pericarditis. Chest X-ray is also recommended, and then the CRP that we talked earlier on, also a class 1 recommendation in this group of patients. So for the chest X-ray, we could possibly find this water bottle appearance, usually on chest X-ray. The ECG could have this saddle-shaped ST segment and elevation in contiguous leads, which we will still see some of them much later. And then the echoes, apart from having pericarditis, some of them could have some form of effusion when the echo is done. And the C-reactive protein can also be used to monitor treatment of patient and response to treatment of patient. So basically for the ECG, the classic finding, they have this ST segment elevation, which I talked about. However, apart from the ST segment elevation, they also have PR segment depression. Could also be found in them. And when we look at the AVR, there's elevation of the ST segment, segment, and often also in V1. So so over the period of days to weeks, there tends to be reversal of this pattern. I think I will show it down the line later, but this is an ECG just to show us ST segment elevation and PR segment depressed PR. The depressed PR segment, it is in 1, 2, Okay, 1, 2. I think also in the next, I think V2, 3, V4, V5, and then in where's AVR. In AVR, it's expected to be like much of an elevation. The PR segment is elevated in then AVR. Okay, so looking at the stages of ECG changes, there are 4 stages basically. The first one, so when okay, accompanying the onset of the acute pain, and the hallmark of acute pericarditis, and what we find on the ECG is the concave shape, the ST segment elevation, except in AVR and V1. Okay, then the T waves are upright in the list with ST segment elevation, and the PR segment depression, as in deviates to the opposite. It's a depression of the PR segment. So in stage 2, which occurs days later, there's a return of the ST segment to baseline, which is followed by flattening of the T waves. And then for stage 3, the T waves becomes inverted without Q waves. And then for stage 4, the T waves returns to normal, or inversion could persist if there's a chronic inflammation. Okay, so we also have the spodic sign, which is said to be found in about 30% of the patient with pericarditis, and it's usually best visualized in lead 2 and the lateral precordial leads. And so it's like a downsloping around the TP, the end of T to the beginning of the P wave, then as we can appreciate then the picture. So other investigation, the C-reactive protein can be highly sensitive. C-reactive protein is elevated in approximately 75% or 3/4 of a patient with acute pericarditis, and it can also be used to monitor the progression, and it could normalize within a week, and in almost all cases by 4 weeks after the initial evaluation. So I think we've talked about chest X-ray, the echo findings, and the CT and the MRI are very important in helping us to detect pericardial thickening. And the MRI provides evidence of active inflammation based on the gadolinium uptake. And then this is on the gadolinium uptake. And then so this is just a chest X-ray showing the water bottle appearance. Okay, this is echo where we have pericardial fluid, pericardial effusion with some indentation, some form of indentation on the right atrium there. Okay, so so other investigations that could be done, ANA, especially for patients who have connective tissue disease, the full blood count can also be helpful in managing the patient better, checking for troponin to rule out other conditions, and also important in that regard. So for the treatment, basically, it's hospital admission is recommended for patients who have an high risk, and when they're looking at those 4 prognostic factors that will actually make patients to be high risk, patient running fever more than 38 degrees, patient with subacute disease cause, large pericardial effusion, apart from pericarditis, which the pain as it were when the patient complains, with the investigations that will be done when we see the large pericardial effusion or a tamponading physiology, that patient should be under close monitoring. And then unsuccessful therapy with aspirin or NSAID after a week of therapy, immunosuppression, amongst other things there. Okay, sorry, this picture doesn't look very clear, but just looking at the recommendations, the class 1 recommendation for treating acute pericarditis is to give aspirin or NSAID, and they're recommended as a first line for acute pericarditis. And while we're doing this, we should also consider gastroprotection for patients by putting them on the PPIs. So colchicine is also recommended as a first line. However, it's an add-on to the aspirin and then the NSAID. And the CRP should be considered to guide the treatment length and assess response to therapy. So if the levels are going down, it means you're possibly winning. If the levels are a bit persistent, you might still need to extend giving the patient NSAID. So low dose corticosteroid it said should be considered for acute pericarditis in cases of contraindication or failure to aspirin or NSAID or cortisone, and when an infectious cause has been excluded. However, this is a class 2 A recommendation, and then it's also advised to actually restrict exercise for a patient undergoing treatment for pericarditis with an acute pericarditis until there's resolution of symptoms and the normalization of the ECG, the echo, and also the CRP level drops. So for athletes, the duration of exercise restriction should be considered until resolution of symptoms also. And then, so steroid is not recommended as first-line therapy for acute pericarditis. That's the class 3 recommendation. So for recurrent pericarditis, aspirin and NSAID are the mainstay of treatment, and they're recommended at full doses if tolerated until complete resolution of symptoms. And colchicine can also be should also be added in recurrent pericarditis. It can be used for 6 months with the adjunct to aspirin and NSAID. And so colchicine therapy more than 6 months should be considered in some cases according to clinical response, which is a class 2A recommendation. Okay. So other things that should also, apart from the CRP level, drugs like intravenous immunoglobulin, and can also be considered in cases of, sorry, please, 1 minute.
Chief. Thank you so much,
Okay.
Chief Augustine. Dr. Augustine.
So, yeah.
Can you hear me?
Yeah.
Sorry,
Sorry, please.
like to take. I understand. We
So,
please like to take a pause, maybe for like 2 or 3 minutes, so that you can
let me
have
just
some.
take water. 1 minute. Okay.
Oh, so sorry that we are stressing your vocal cords tonight. We appreciate your
Sorry, I
sacrifice. Thank
have to do this one. Thank you. Okay, so for patients who are resistant to corticosteroid dependent recurrent pericarditis, they can actually benefit from azathioprine, intravenous immunoglobulin, which is a class 2B recommendation. And then exercise restriction should also be considered, whether they are athletes or non athletes also. Okay. Okay. So, so if ischemic heart disease is a concern or antibiotic therapy is required, aspirin should be start at a minimum high dose. And so let me just go to the last one here. So, like they said initially, corticosteroid therapy is not recommended as a first line, even for recurrent pericarditis. We should try the NSAID first before ending it up with the steroid. So for acute idiopathic pericarditis, it's said to be self-limiting without significant complications or recurrence in 70 to 90% of patients. And NSAID should be initiated. And because of its excellent safety profile, the ibuprofen can, apart from the, I think the usual those people give is this 400 milligrams. You can step it up to 600 to 800 milligrams 3 times a day. And acetylsalicylic acid can also be given 2 to 4 grams daily in divided doses. And the gastroprotection should also be considered. And like I said initially, colchicine improves, is an add-on which improves the initial response when used in conjunction with NSAID and reduces the chance of recurrence. Okay. So I think we've talked about most of this. Okay, so complications that could occur, patient could have an effusion, could have a tamponadine physiology, and could have constrictive pericarditis over time. Okay, so so talking about pericardial effusion, presence of abnormal amount of fluid or abnormal character of fluid in the pericardiac space. And so increased production of pericardiac fluid could result from inflammation and then decreased absorption due to general increase in systemic venous pressure as a result of heart failure or pulmonary hypertension. And then in developing countries, tuberculosis is said to be the predominant cause in developing countries. However, in developing countries, in developed world, the causes are said to be idiopathic, and the other etiologies to consider will include cancer, other infections, and connective tissue diseases. So to classify pericardial effusion, depending on the onset, acute, subacute, chronic, then the size, when it's less than 1 centimeter or 10 millimeter, is mild, 1 to 2 centimeter, or the millimeter conversion is a moderate, then more than 2 mm or 2 centimeter is severe. And then the distribution can also be classified based on the distribution, whether it is circumferential or it's loculated, and the constituent of the effusion, whether it's the transudate or it's exudate. And the clinical presentation of pericardial effusion varies according to the speed and size of pericardial effusion. For those who have rapid accumulation of fluid, symptoms, they could actually be more symptomatic compared to those who have slow accumulation of fluid, which gives space for the pericardium to be able to adjust to that chronic state, and the fluid could be really a lot at the end of the day, compared to those who have rapid accumulation. Because of that rapid accumulation, the pericardium tends to be kind of stiff on time. We use it explain like that, and it wouldn't allow it to be much more before you possibly start having symptoms. So part of those presentation, they could have dyspnea on exertion, okay, and they could have autopnea, they could have chest pain, as it were. Then there could be features of compression, okay, on the diaphragm, could make the patient to feel nauseated. Esophagus, it could make them to have difficulty in swallowing. When it impinges on the laryngeal nerve, recurrent laryngeal nerve, will make them to have hoarseness of the voice, and the phrenic nerve make them to have hiccups. So a number of the symptoms are non-specific, from cough, weakness, fatigue, and anorexia palpitation. May not actually be able to pinpoint anything in particular. So findings of pericardial effusion, depending on the size, if it's mild, so even some moderate may be normal as it were, okay? However, for patients who have a tamponadian physiology, which is the next thing we talk about, they could have this neck vein distension with elevated JBP, pulsus paradoxus, diminished hearts, and on auscultation. So to make assessment of pericardial effusion, transthoracic echo is a class 1 recommendation, which should be done on all patients. Chest X-ray is also important. The CRP helps in the assessment of inflammation, and recommended in patients with pericardial effusion. And the CT-MRI can also be considered in patients who have loculated pericardial effusion, pericardial thickening, or masses, as well as some abnormalities in the chest. So for management of effusion, it will be dependent on the size, and if it causes any hemodynamic compromise. So especially treatment will be necessary if we have a tamponadian physiology, and also to assess for the possible associated disease, the underlying disease condition of the patient. So we need to try and treat the underlying. If it's tuberculosis, for example, we take care of the tuberculosis. If it's a fungal infection, it will be treated. Then we can also treat for pericarditis and pericardiocentesis if the patient is symptomatic. And some patients could have a pericardectomy, or to have a pericardial window if the fluid reaccumulates, or if the effusion is depleted. So for the ESC guideline, it's recommended to target the therapy of pericardial effusion with respect to the etiology, and then aspirin, NSAID, colchicine are also still class 1 recommendation. And pericardiocentesis or cardiac surgery is indicated for cardiac tamponade or for symptomatic moderate to large pericardiac effusion, not responsive to medical therapy, and for suspicion of unknown bacterial or neoplastic etiology. So now talking about tamponade, it's the accumulation of fluid in the pericardiac space in a quantity sufficient to cause serious obstruction to the inflow of blood into the ventricles, which results in a tamponade, cardiac tamponade. And the complication may be fatal if it is not recognized on time and promptly treated. So the three most common causes of a tamponade are the neoplastic disease, idiopathic pericarditis, and renal failure. And the tamponade may result from bleeding to the pericardiac space during cardiac surgery or during trauma, maybe penetrating trauma, and treatment of patients with acute pericarditis with anticoagulants could also make them to tamponade, to have a tamponade physiology. So the three principal features of tamponade is we have the Beck's triad, and then so for the Beck's triad, there's hypotension, there's a soft heart and jugular JVPs distended with prominent X descent. So usually for normal physiology, during inspiration, we expect the pressure in the right atrium to drop. Okay, so and so with normal inspiration, also you expect that the thoracic the pressure in the thoracic cavity usually drops. So with that drop in the pressure in the thoracic cavity, it allows the lungs to suck in air, and at the same time also allows the heart to suck in blood from the IVC, the HVC, superior vena cava also, and this will improve your venous return usually. But however, when you now have a tamponading physiology, I think I should go to, okay, maybe I should, let me delete that too. I have a picture so that to make much more sense. So there are both limitations to, it causes limitations to ventricular filling and also reduction in cardiac output. So so the quantity of fluid necessary to produce, make a patient to be in a critical state could be as small as 200 mils. Usually when you have a rapid accumulation, okay, patient could actually be more symptomatic. And for those who have a chronic condition where there's gradual accumulation of those fluid, symptoms may not be obvious until when you have something in the range of 2 liters in the pericardium. Okay, so for the etiology of pericarditis, sorry, tamponade, most of the things that will cause the pericarditis are actually culpable in this regard. Okay, so for this little diagram here, so for those who have, okay, for those who have a cardiac tamponade, this is the heart in the center as it were, like this. Okay, and surrounding the heart we have like a form of circumferential fluid. So in this kind of instance, there's increase in the intrapericardiac pressure. Okay, and when the intrapericardiac pressure increases and overcomes the intracardiac, then it will have a collapse. So it's as if the fluid is trying to squeeze the heart, as it were. Like I was trying to explain earlier on, usually the normal physiology, so during inspiration, you normally expect a drop in the JVP, and then blood should be kind of sucked into the right side, into the right side of the heart. Okay, and also during this inspiration, there's also a reduction in the pressure in the thoracic cavity will drop. So with the drop in the pressure in the thoracic cavity, the lungs on the spot can suck in more air. Okay, and also the blood can easily flow from your IVC to also empty into the right side of the heart. Okay, so you expect increased blood flow. But when you have a tamponade, so which is trying to like collapse both the atrium and the right atrium and the right ventricle, So it will mean that the quantity of blood that can be received is minimized. So when you have a reduction in the quantity of blood that goes in, over time, you tend to have reduction in your what's it called now? The end diastolic volume. And when you have reduction in end diastolic volume, there will also be reduction in your stroke volume and your cardiac output eventually. Okay, and all of this will play out when you have a high intrapericardial pressure. Okay, from the arrows on the outside now, it's trying to actually compress in on the heart as it were. So you won't be able to get enough to go inside. So over time, if the condition persists for long, then the patient will likely present with hypotension because there's reduction in the inflow. And then when you have a reduction in inflow, there will also be reduction in the heart flow in your cardiac output. So when you examine those kind of patients, you may notice that they start to have these cool and clammy extremities, and you tend to have a low mean arterial pressure. And this could also trigger the baroreceptors, okay? And then, so with reduced perfusion, the baroreceptors send a message to the higher centers, your medulla, and it will increase sympathetic outflow. And then with the increase in the sympathetic heart flow, there will be increase in the heart rate. So you find patient going into hypotension, and on the other side also, they have a tachycardia, okay? Because of the reduced perfusion also, some of them will also become a dyspneic over time. And then just a quick revision of the waves in the JVP. The A is atrial contraction. The C is the closure of the tricuspid. C is the closure of the tricuspid of the valve, and the X is atrial diastole, relaxation of the atrium, which is usually more prominent in patient with cardiac tamponade. Our V is usually due to venous inflow, and Y is due to opening of that tricuspid valve. So Y is usually absent in patient with tamponade, and what might actually explain is that even if the atrium were able to receive a little inflow, okay, it's supposed to empty its content into the right ventricle. But when you have collapse of the right ventricle, so how do you now even get to empty what the atrium has? How does it get to empty it into the right ventricle? So it might impede the Y wave, which is actually due to the inflow of opening of that tricuspid valve and inflow into the right ventricle. So you tend to have increased low blood pressure, tachycardia, you have increased JVP, and you have prominent descent, basically. So I think I've been able to explain a number of these things so that we can move a bit faster. So you could also have a paradoxical impulse, and it's an important clue to the presence of cardiac tamponade. And therefore, paradoxical impulse, as we all know, during systolic blood pressure, there's a drop. During inspiration, there's a drop in systolic blood pressure by more than 10 millimeters of mercury. And then when severe, you may even find it difficult to get a good pulse from the patient. The pulses may usually be weak, and they could even disappear during inspiration. But usually the peak measurement of systolic blood pressure during slow respiration is required. So since both ventricles share a tight, incompressible covering, okay, the pericardial sac. Okay, let me explain this like this. So usually, so with the during inspiration, there's increased flow of blood into the right side of the heart. So there could be a shift in the septum to the left side. And when that happens, it will lower the pressure and the volume in the left side. So you notice that during inspiration, the cardiac output will likely reduce because of so much pressure in the right. It will actually shift the septum to the left, and there will be reduction in the pressure and the volume in the left side. However, in expiration, the pressure on the left will increase, and there could now be reduction on the right side, basically. Okay, so I think I've been able to explain some of. Okay, so so not just only tamponade will give us pulsus paradoxus, we can also find it in patients who have right ventricular infarction, okay, which may make it look like a tamponade because they're going to have hypotension, also increased JVP, absent wide descent in them, and okay, and then also I think also apart from that also okay, paradoxical pulse occurs not only in cardiac tamponade but also in a third of patients with constrictive pericarditis. Not all of them, but a third of them we have pulsus paradoxus. However, for constrictive pericarditis, Kussmaul sign seems to be more on the list for constrictive pericarditis. So this physical finding is not pathognomic of pericardial disease alone. That means the pulsus paradoxus. Patients who have some respiratory issues, obstructive airway disease, pulmonary embolism, can also have pulsus paradoxus. Okay, so for the examination, I think we've been able to discuss a number of them during the pathogenesis. A complete physical examination of a patient with pericardial effusion will provide give us some clues. So in pericardial effusion without tamponade, your findings will usually be normal. However, for those who have a large, when there's large effusion, it can be difficult to even pick the heart sound. The heart sound are usually muffled in those kind of situation. And some of them may also have a frictional rub. And there's I think the Ewart sign or the pin sign, where you have this bronchial breath sound around on the back. When you listen, how do I explain it now? Around the left axilla or the base of around the scapula behind there, around that, let me say around in the left axilla, you listen to a bronchial breath sound there, the tubular breath sound there, which is referred to as the Ewart sign, or sometimes they also refer to as a pins and sign. And the Bextra, which we talked about, is also can be picked up during examination. So okay, so patients with tamponade appear uncomfortable with signs reflecting varying degrees of reduced cardiac output or shock. So they could be tachypneic, they could be diaphoretic, they could have cold extremities, which we talked about earlier on. Some of them could have peripheral cyanosis, and as it worsens, some could even have altered sensorium. So hypotension with reduced pulse pressure is usually present. Although, like I said, in the early stages, there seems to be compensatory mechanism to maintain the blood pressure when you have increased sympathetic outflow usually. And so for patients who have tamponade, paradoxical pulse is the rule, but it's important to be alert of situation in which it may also be absent. So I think we talked about tachycardia, we talked about raised JVP, and we talked about other things that could look like it, like pulmonary embolism, right ventricular infarction. Okay, so for the ECG findings in tamponade, they tend to have a reduced voltage complex, and bearing in mind that it is just not pathognomic of cardiac tamponade or alone. Emphysema, infiltrative myocardial diseases, pneumothorax can also have a low voltage complex, and they could also have this electrical alternance, which is specific but relatively insensitive in large effusion. So, and this is due to when you have swinging of the heart, which is caused by anterior posterior swinging of the heart with each contraction. Okay, so with one contraction, it could actually, let's say up and down, for example, now it could like bounce up, so to speak. Then next contraction, it bounces down. Okay, within that pool of fluid. So when we look at the ECG and you look at the QRS complex 1 would be tall, 2 reduced, and 3 tall, as in alternating like that. So gives us electrical alternance. And so when pericarditis coexists, the usual findings of the ECG may be present. Okay, so this is just X-ray showing what looks like this water bottle kind of appearance. I think we've talked about that earlier on. Then also, so the chest reveals the normal cardiac silhouette until effusions are least moderate in size. And with a larger effusion, the anterior-posterior cardiac silhouette assumes a round flask-shaped appearance. And looking at the lateral view, you could have a linear lucency, okay, like a dark spot, as it were, between the chest wall and the anterior surface of the heart, which is caused by separation of the pericardial fat from the epicardium. Okay, so for echo, patient echocardiographic technique remains the standard non-invasive method of detecting pericardial effusion and then tamponade. And then an effusion appear at a lucent separation between the periureter and the visceral pericardium for the entire cardiac cycle. So for small effusions, it could be found around the posterior part of the left ventricle. So as it increases, it spreads anteriorly, laterally, and behind the left atrium, where it limits. Sorry, please, 1 minute.
Yes, sir. Sorry, sir.
1 minute, please.
Are you almost done? How many more slides?
Okay. I think we still have constrictive pericarditis, and then I think I will wrap up this one fast now. So because of the rapidity of accumulation is critical. So the hemodynamic significance of an effusion does not always correlate with its size. So, however, tamponade does not usually occur without circumferential effusion, usually, okay? And they could also have loculated effusion that could cause tamponade. So in those reloculated, we could see this front-like shaggy appearance, which could be suggestive that there's clots or chronic inflammation or neoplastic pericardial process. And the CT and the MRI are a bit more precise on examining the pericardium. Okay, so tamponade is best considered as a spectrum of severity of cardiac compression when you have an early diastolic collapse of the right ventricle, late diastolic indentation or collapse of the right atrium, and you have exaggerated variation in the right ventricle and left ventricle chamber size, and interventricular septal shifting, what I was trying to explain with when you have inspiration and the septum tends to shift towards the left, and then when you have expiration, tends to shift towards the right. Okay, so talked about them, so we can move a bit faster. So also other things that we could also find the distension of the cava versus your inferior vena cava, which does not diminish with inspirations, and other useful signs which can be found in these patients. Okay, so like we said initially, the CT and MRI can also be used, and then MRI with gadolinium uptake more specifically identifies inflammation and includes to the nature of the pericardial fluid can be gained from CT attenuated coefficient. So when the attenuation looks like water, it is said to be transudative fluid. When the attenuation is greater than water, it's said to be suggestive of malignant pathology, bloody or purulent substances. But when the attenuation is less, a chylous fluid should actually be considered. And so the CT scan, for the CT scan, where you have a massive effusion associated with a thicker pericardium than benign effusion, could actually make you think malignant condition. And usually when the pericardial thickness is more than 4.1, okay? So this is just lumpectomy view here, showing a large pericardial effusion on this side, and also around the free walk around the right ventricle here. And then I think we have some of those pictures there, they are drawn here. So, but if you look at the middle one, there's an indentation on the right ventricle here, collapsing the right ventricle there, which shows a tamponade there. Okay. Also, this apical 4, we have an indentation of the right, what's it called now? Right atrium there. This apical 4 view. Okay, this is just a video of someone who has a tamponade. Okay, I think can appreciate the collapse around the right atrium. Let's quickly move forward. Sorry, let me move forward. 1 minute, please. Okay, so for the management, it's indicated first and foremost by whether the tamponade is present or has a high chance of developing the near future or near term. And in the absence of the actual or threatened tamponade, management can be done much calmly. However, in cases of a in which the tamponade is neither present nor threatened, and a cause will be evident and or suggested from the history if the patient had had plastic disease, exposure to radiation. So all those things can actually be consideration. Okay, so patient with actual or threatened tamponade should be considered for as a medical emergency. However, for patients who do not wish for prolongation of life, hospital admission and careful hemodynamic, for patients who do not wish for continuation of life, you might not be able to do much for them. However, hospital admission and careful hemodynamic and echo monitoring are very important in this group of patients. Most patients will require pericardial to treat or to prevent a tamponade in them. And then so also apart from taking out the fluid, they said that some patients may also benefit from having an NSAID, colchicine, in the hope that the effusion will shrink rapidly. And a patient with connective tissue disease and some inflammatory diseases can be treated in the same way with a course of steroid. But however, there is no evidence that steroid increases recurrence in this patient. So that we can move a bit faster. I think it's just pericardial is just the cornerstone here for most of these patients. So for looking at the medical therapy also, sometimes before you see the cardiothoracic surgeons to help out to see this patient, part of the medical therapy is to give them IV fluid, and the sense of giving them the IV fluid like normal saline is hoping to increase the volume that goes into the heart to kind of reduce the hypotension which they tend to have. And some people also give them positive inotropes, which can be used, but they are said to be of limited efficacy. And volume expansion and positive inotropes are just temporizing measure. The major thing to do is to actually get the fluid out of that space. Okay, for those who have loculated effusion or effusion containing clot, fibrous material are also of concern because the risk and difficulty associated with the closed pericardiocentesis are increased. So if removal of the fluid is thought to be necessary, an open approach should be considered for safety to obtain pericardial tissue and to create a window for this group of patients. Okay. Okay, just to speed up what we have, I think we've talked about most of this. So we can move to constrictive pericarditis. So for constrictive pericarditis, it's an end stage of inflammatory process involving the pericardium. So in the developed world that was talked about earlier, it's usually idiopathic, post-surgical, or due to exposure to radiation. And on our side of the divide, tuberculosis seems to be the main culprit on this side of the divide. So constriction can follow initial insults over several months and occasionally less, but it typically takes years to develop. And the end results, we have a fibrous, often with calcification and the addition of a parietal and the visceral pericardium. So that's scarring that occurs there also is generally more or less symmetrical as around the whole pericardium and impairs a filling of the heart chambers. So in a subset of patients, the constriction is transient or reversible with the use of an anti-inflammatory, just a few number of patients. And this is observed early after cardiac surgery, and another patient who appear to have intense pericardiac inflammation. So causes of constrictive pericarditis are still things we can relate to from what we had earlier on. Okay, so looking at the pathogenesis, the green part is like a rigid case, okay, which wouldn't allow the which will not allow the heart to which will not allow the heart to which will not allow the heart to be able to receive blood, so it will impede that diastole. So the heart is in a form of encasement, and there's impaired ventricular filling due to increased right atrial pressure. So for the atrium to be filled, it will be done at a high filling pressure. And we have a Kussmaul sign here, because with inspiration, you expect that the pressure on the right side should drop, but it keeps they do have this paradoxical increase in the pressure on the right side, which can also be found in them. So because of this encasement, they also tend to have equalization of pressure in all the cardiac chambers, also involving the systemic and pulmonary veins. There's a equalization of pressure there. And then so you tend to have as opposed to tamponade, where we have just the prominent X and then the Y is almost nowhere to be found. Here we have a prominent X, and then the Y is a bit deeper. Is a bit deeper, and then so the sharp and the deep Y descent of the JVP is also referred to as a Frederick sign, usually. Yeah. Okay. So the pathologic consequence of pericardial scarring is markedly leads to restricted filling of the heart, which I just tried to explain, and there could be equalization of pressure in the chambers, systemic, venous, and veins. And during early diastole to mid-diastole, ventricular filling abruptly ceases when the intracardiac volume reaches the limit set by the stiff pericardium. So during diastole, we have the rapid filling. The diastolic phase, we have the aspirometric relaxation time, the rapid filling diastasis, and then the atrial. So with the rapid filling, because the heart is trying to receive enough blood, but that ability to be able to distend is impeded by the stiff pericardium. And then these are the point where we usually tend to peak pericardiac knock in this patient. So some of these patients will also over time have, because of the backflow, the heart is trying to fill, but the pressure in the right atrium is high. So it's difficult to actually get that. So there's this backflow back. So they tend to have hepatic congestion, pleura edema, ascites, cardiac cirrhosis, and with the reduced cardiac output, okay, due to impaired filling, there will be fatigue over time, weight loss, muscle wasting. So in a pure constriction, it is said that the contractile function of the heart is still preserved, okay? But the ejection fraction can actually be reduced, one, due to reduced inflow into the heart, in the right heart. So when you get little in, then you push a little out, okay? On one part, that can affect the ejection fraction. Then on the other part also, some patients tend to also have inflammation of the myocardium, not just the pericardium now. The myocardium can also experience some form of inflammation and fibrosis, which will impact on the contractility of the heart. So on either side of the divide, over time, the ejection fraction will really come down. Even after the patient has the stripping of the pericardium done, the ejection fraction may still not improve significantly. So for the clinical features, I think we talked about them. Right side heart failure features will be there at an early stage. Findings include edema, I think we talked about them, edema, cardiac cirrhosis. So some of them could also have atrial fibrillation and tricuspid regurgitation, which will further exacerbate elevation in the filling pressure, okay? And at other points, some patients will have recurrent pleural effusion, and some may even experience syncopal attack. So still on the physical, so the physical examination, the JVP is elevated and with a rapidly collapsing Y descent. And so this combined with the normal X descent results in a what looks like M or W shaped venous pressure contour usually. Okay, I think we've talked about small sign. Okay, so like we said initially when we're talking about tamponade, about a third of these patients we have paradoxical pulse. And then for the pericardiac knock, like I said initially, during the feeling, it's due to the abrupt cessation of feeling of that ventricle. So at that point, you get to pick a diastolic knock, and then the apex may not be palpable. The heart sound are usually soft, and then and early thought and sound usually coincide with the diastolic knock. So in the pulmonary area, there's sudden instantaneous widening of the splitting sound, which occur following the first bit of inspiration, which is this German word, Vogelpoel Beck sign. So I think we've talked about the congestion, so we can also move on. So to the investigations, they could also have low voltage complex, and the atrial fibrillation is not uncommon in this group of patients. For the chest X-ray, the cardiac silhouette can be enlarged because of the coexisting pericardiac effusion, and the pericardial calcification is seen in a minority of patients and suggests tuberculosis, but it is not itself a diagnostic of constrictive physiology. Okay. This is just an X-ray showing calcification around the pericardium there. Then, so looking at echo is important to make in assessing these patients. And so part of the things that could be found in echo, to find pericardial thickening, that could be septal bumps, okay, which because of the increased pressure on the right side, that could be this abrupt displacement of the septum, which moves towards the left side. So there could also be signs of systemic venous congestion, and the patient could have dilatation of the hepatic vein, the IVC, okay, and the blunted respiratory fluctuation, and the exaggerated septal shifting in the respiration. And okay, so during inspiration, on the right side of the heart, okay, during inspiration, there's looking at the echo now, the E and A wave, okay, the rapid feeling and the atrial kick. During inspiration, there's increase in on the right, there's increase in the E, and the A is reduced. However, on the left, now it's like there will be a reduction on the left because there's during inspiration, the pressure increases on the right side of the heart, so it reduces the flow and the pressure on the left side of the heart. However, during expiration, the pressure on the left side increases, and then it's reduced on the right side of the heart, as we can see from the EA ratio, which was shown there. Also for cardiac characterization, which is important in this patient, looking at the first diagram we have at A, we have the blue and the red line here. And so I think Prof explained this a couple of weeks ago. So looking at the right ventricle now, which is the blue line, okay? So going down shows the infilling, okay? So you get to a point with the abrupt stop in the filling, okay? So the pressure starts to rise again, okay, in the right ventricle, okay? And when the pressure gets to a point, it forms a plateau, as we can see here, okay? And then also looking at the left atrium, okay, we also have filling, okay, filling two stops at some point, and the pressure starts to increase, okay, when it comes up here. So a form of equilibration of pressure, which is referred to as the square root sign, also referred to as a dip and then peak, the pattern here. So to also show us that there's equilibration of pressure all around, like this, the B picture, the blue is the right atrium, and then the left is the red is the left ventricle. Looking at the left, like we talked about, there's infilling here, okay, and because the ventricle can distend to receive more, okay, there's an abrupt stoppage at those points, and the pressure starts to build up, okay, and plateau there. And the right atrium also experience infilling, and then abrupt stoppage also, and the pressure is like equal at that point. So the CT is also important, which could show pericardial thickening. For management of pericarditis, basically it's surgical, but we can just do some medical treatments, and then to restrict the salt intake, give diuretics to relieve volume overload, and but patients ultimately will become refractory to this form of treatment. And because they tend to have tachycardia, and this tachycardia is a compensatory mechanism, so it is advisable to be careful with putting this patient on beta blockers, which will slow the heart. And so beta blockers should really be avoided in this group of patients. Likewise, our calcium channel blockers also, okay? And so in patient with atrial fibrillation and a rapid ventricular response, DICH is recommended to slow the rate before resorting to beta blocker or calcium channel blocker, basically. And the recommended rate not to be allowed to drop below 80 to 90 beats per minute. So the last one, effusive constrictive pericarditis. So patient with pericardial disease may have a syndrome that combines the elements of effusion, tamponade, and constriction, which is termed effusive constrictive pericarditis. Okay, most cases of transient or medically treatable constrictive pericarditis probably represent a late stage of the effusive constrictive pericarditis. Okay, so an inflammatory effusion typically dominates early, with constriction coming up much later in this pathology. And the visceral pericardium is usually prominently involved. So, so this patient often identified when the hemodynamics fails to normalize after pericardial synthesis. So, commonly accepted definition is failure of the right atrial pressure to drop, to decline by at least 50% to a level below 10 millimeters of mercury when pericardial pressure is almost reduced to zero by pericardial synthesis or detectable fluid when detectable fluid is removed. Okay, and so the reported incidence of effusive constrictive pericarditis in patients with pericardial effusion is approximately 4 to 5%, but varies from 1 to 15% in different series. And the causes are diverse, with the most being idiopathic, could be malignancy, exposure to radiation, tuberculosis, connective tissue disease, and like we said initially, TB is the leading cause on this side of the divide. So to make diagnosis, we require acquisition of the pericardial fluid and biopsy specimen if the cause are not so obvious. Okay, it is important to be cautious when performing close pericardial synthesis in patients with this large effusion. So for the management is tailored to the specific etiology, the cause if it is known. So in idiopathic cases, anti-inflammatory treatment may be used in an attempt to avoid pericardectomy, but no guidance is available to the best approach possible for this patient. So in idiopathic and post-pericardectomy cases with tamponade and the effusive constrictive physiology documented at the time of pericardial synthesis, a course of steroid with colchicine is outlined for medical treatment of constriction. And the pericardectomy is usually required in many of these patients. So just a table just to differentiate most of the stuff we talked about earlier in the morning, in the day, I mean. The pulsus paradoxus is commonly found in patient with tamponade as opposed to patient with a constrictive pericarditis. However, Kussmaul's sign, like I said earlier on, is found predominantly in patient with constrictive pericarditis as opposed to tamponade. Okay, and pericardial knock is also exclusive for constrictive pericarditis. Both of them will have low voltage complexes And the tamponade will have electrical alternance because of the amount of fluid. It keeps tossing the heart back and forth, basically. So to explain why they have a electrical alternance. So the echo in constrictive, because it happens over a period of time, the sticking of the pericardium, the calcification, and then you might not see an effusion as opposed to tamponade where effusion that is impinging on the ventricle or the atrium is what we have there. Okay. Then I think we've also talked about the equalization of pressure, which is usually present in it's usually present in can be found in tamponade and also in cursor, okay, and in what's called a constrictive pericarditis. But in a patient who have a restrictive cardiomyopathy, the difference between the right and left is said to be more than 5 to 6 millimeters of mercury. Thank you for listening. Please, contributions.
Thank you so much. Okay. Yes. Thank you so much, Chief Augustine, for your presentation. Please, like our lecturer, ask contributions, comments, questions. Thank you. Please, was I audible?
Yes, you are audible. Yes, I can
Okay,
hear you.
Chief. You're welcome, sir. Thank you. Since there are no questions for you, Dr. Odai, thank you so much for a very lucid and beautiful presentation. There are colleagues in the chat box too saying the same thing. Thank you so much, sir. We appreciate you taking us through this lecture despite the little challenge with your voice. Thank you, sir.
You're welcome.
Okay. In the absence of further comments, possibly we just move to hello. Yes.
Good evening all.
Cool. Chief Sawa, good evening. Yes, you have the floor, sir. Thank you.
All right, thank you very much for this very exhaustive and lucid presentation. Just some few comments with respect to the use of corticosteroids in acute pericarditis. One of the main reasons why it is not really publicly advised to use, because most times research has shown that most people who use steroids in acute pericarditis tend to have chronic relapsing pericarditis that most of the times they dependent on these steroids. Some of them, by the time you start tapering down the steroids, you see them also having a relapse of that pericarditis. So one of the major reasons why it is strongly advised against the use of steroids acute pericarditis. And another thing again that I think is important that we should also pay attention to is the NSAID that is being used in acute pericarditis is actually a very high dose NSAID. And it's also said to be, it's very important to exclude the presence of a coexisting myocardial infarction before you start that NSAID, because it has also been found that the use of that degree of NSAID in a coexisting myocardial infarction is likely to worsen the infarct. And colchicine, lastly, colchicine is contraindicated. You need to be careful in administering colchicine in patients with renal insufficiency and those with hepatobiliary disorders, blood dyscrasias, and also patients with GI motility disorders. Thank you very much. There's a few additions I want to note. But by and large, I really enjoyed the presentation. Thank you very much.
Thank you, Chief Sawa. Please, any further comments or questions? Okay. Once again, thank you very much, Dr. Doyle. Thank you to everyone. We move ahead to Prof MCQ book. Dr. Doyle, can you kindly unshare so that somebody will help us share Prof book?
Okay, 1 minute. Let me just do that.
Thank you so much. Chief Uzoki, over to you, sir. Thank you.
Thank you, Adeyanju. Thank you, everybody. Good evening.
It is that. I can't. So, I need a little help. I'm not too sure what. I think the icons. I'm not so used to.
Okay. You are using your system, sir?
Yeah.
Yes, you press on stop share or stop. Yes.
Okay. Share. Okay. Share screen, right? Okay.
No, as
Okay.
in we can't see your slides again, Dr. Odai. You stop.
Do you want so
Chief Odai, I couldn't hear you. I don't know what you're saying. Maybe your network, if you can type in.
okay. Can someone share now? Please
Yes, someone
try
can share now because you've unshared. Yes, someone can share now because we can no longer see your own slides, sir.
Okay.
Thank you.
Thank you.
Good evening.
Good evening, Dr. Ozuki. Chisawa, you were helping us to share. I hope it's not his network.
Oh no, I just did that in order to take off his phone because he was having challenges on sharing his own side. So I think
Chisawa,
the screen is
Chisawa,
free now. You can share the question.
yes. Thank you, Chisawa. You are Chief Joseph here, sir. Thank you so much. We appreciate it.
Okay, if you want me to share, I have to start looking for. Let me see if I can download Prof.
Oh, really?
And
Okay.
that will take some few
That will take
minutes.
some few minutes. Yeah.
Let me see.
Is there any other person that have it easily accessible? And it's not really easily accessible with Chisawa. Any other person can please kindly approach share just to be able to make better use of our time. Chief Kweki, sir. Chief Kweki, are you there, sir? We are done with the curriculum, sir. Possibly it's busy.
Sorry, just a little longer to come up. Hello. 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 Am I audible? Hello.
Yes,
Okay.
yes.
Yes, sir, you're audible, sir. Thank you. I think we
Okay.
are starting from Dr. Ozuke's part 1 to 10. Thank
Okay.
you,
I thought
sir.
I thought I was the one that. Okay, there was someone who couldn't present before.
Somebody is owing us
Okay.
section
Number
8,
one.
1 to
What
10.
number is that?
Thank,
1 to 10.
yes, thank you, sir.
Okay. Let me go to number 1. Okay. Here we go.
Thank you very much. I think I can start right away, right?
Yes,
Good evening,
sir.
everybody. Can you hear me?
Yes, sir, you're audible, sir.
All right,
Thank
thank
you.
you very much. Section A, question 1. Which of these geographical factors is most relevant in arterial wave reflection? They say altitude above sea level. They say high temperature. Say low temperature, relative humidity, snowfalls. Now, I tried to look up this arterial wave reflection, and it just stated that the change in dPdt, that's the change of pressure, arterial pressure changes over time, reflects the cardiovascular mortality and morbidity in each individual. And the change is usually higher in the elderly when the elasticity of the arteries are reduced. So among the things they named there was altitude, I couldn't see snowfalls there and all that. So I couldn't get much again about the arterial wave reflection. So this thing on this book is correct. Altitude above sea level. Thank you very much. I don't know if there is any further contribution, otherwise I'll move on. The following factors factor does not cause false elevation of troponin I. Of course, we know that an analyzer malfunction can cause spurious elevation of troponin I. Same thing with heterophile antibodies. Of course, hemolysis and fibrin plots. Now, elevated transaminases. I think this only shows the damage in the liver enzymes, in the liver cells, and does not necessarily reflect cause an elevation of troponin I. So I think the correct answer here is elevation in transaminases. Number 3. Left ventricular dilatation is reliably shown on AP chest X-ray as cardiomegaly. It will be shown as cardiomegaly with left ventricular preponderance. That is to say, the left ventricle will be approaching will be aborting the left thoracic cage. Lateral chest X-ray is as cardiomegaly. You know, this lateral chest X-ray as cardiomegaly is incomplete. But lateral chest X-ray as encroachment on the retrocardiac space, that is true. To be closing on the retrocardiac space. Now, lateral chest X-ray as an encroachment of the retrosternal. That is not true. That should be right ventricular enlargement. Posterior anterior chest X-ray as cardiomegaly. That's not correct. That's not correct. Yes, yes. So the most appropriate here, the most appropriate here is option C. Lateral chest X-ray as an encroachment of the retrocardiac space is an indicative of left ventricular enlargement. Thank you very much. Question number 4. In which of the following tissues does ultrasound speed of 1,590 meters per second apply? Well, what I have here is okay, similar to what is here. Blood is 1,500. Bone is 3,000 meters per minute. 3,000 to 4,080 per minute. Fat is 1,450 per minute. Meters per second, rather. Liver is 1,550 meters per second. Bone is 1,580. Air is 330 meters per second. Water is 1,480 meters per second. Kidney is 1,560. Lungs is 700. So the closest here is 1,580. That is 10 meters different from the closest, another closest right by here, which is 1,570, which is about 20 meters per second difference. So the most likely, the correct answer here, the closest answer here is, most appropriate answer here is the muzzle, which is 1,580 meters per second. This paralleling, this handwriting on this paper, I seems familiar. Now, question number 5. From which of the following windows does breath holding in inspiration during echocardiography improve image quality? Taking a deep breath and when you take in a deep breath and hold it, we know that the thoracic cavity will increase and the diaphragm will go, will equally depress, thereby bringing the heart to the inferior space, further to the inferior space. So it cannot be apical here, it cannot be left lateral here, it cannot be right parasternal here, it cannot be suprasternal, of course. So it is actually subcostal. Option D is the correct answer. Question number 6. Which echo view below reduces the chance of echo dropout occurring in the interatrial septum and hence useful for the diagnosis of atrial septal defect? I think the closest hack here, the closest exposure is that most things about the pericardium and the atrium, the clearance is usually subcostal window. Nothing comes better than that in most pathologies. So apical four-chamber is not correct. Apical four-chamber, the only thing that happens is if we begin to use a color Doppler. Apical long axis, parasternal short axis, suprasternal will not even help us at all. So the correct answer there is C, subcostal view. Question number 7. In stage 2 diastolic dysfunction, deceleration time is normal.
Hello, sir.
Yes, sir. Yes, sir.
Hello, sir.
Yes, I'm all here, sir. You're welcome, sir.
Thank you very much. I'm so sorry to cut in actually.
Yes, you're welcome.
But I just have a bit of a suggestion.
Yes, sir.
One of the things that helps retention is when you have for and against. Okay.
Okay.
Like for instance, I'm sorry to take us back, but I think the third question or so, or was it the fourth question that concerned the chest radiograph?
Okay.
For instance, why was the last option not the correct option? The point I'm actually driving at is that we have to try and say what makes the other options inaccurate or wrong. Do you understand what I'm saying?
All right. All right.
It's not in every case that we may need to, no, it's not in every case that we may need to. Take, for instance, look at this question 5. The literature tells you point blank that subcostal, in fact, it even happened some weeks, or was it earlier this year? You know, someone, a new registrar, a new senior registrar who was, getting acquainted with echocardiography, actually thought that a patient had, a septal defect. But when I came in, I now said, okay, let's do a subcostal. We looked at it as subcostal, and the echo dropout that he thought was the defect was not on subcostal. So yeah, there are some that you won't really have to do any for and against in for, but there are going to be some that we may need to try and give, some flesh to what makes it improper or what makes a particular option the proper one. It may not be possible all the time, but it may help. I don't know whether I'm even trying. I'm getting across what I'm saying well. I don't know.
But,
Did I
very well? Very well.
sense?
Yes. Adding flesh to it when when it is possible, when it is necessary.
Exactly. That's just what I just wanted to say. Thank you so very much. All right. We fire on, sir.
Thank you very much, sir.
Like for it.
Okay.
Okay. Let's just go on.
I'm all yes.
No. You are doing
All
well.
right.
You are doing well. I don't want to. Yeah.
All right. Thank you. In stage 2 diastolic dysfunction, A, deceleration time is normal. Deceleration time is increased over 240 milliseconds. Isovolemic relaxation time is over 90 milliseconds. Pulmonary vein A wave reversal is less than 25 cm per second. Deceleration time is reduced to less than 160 milliseconds. Now, in stage 1 diastolic dysfunction, we have a impaired relaxation where EA ratio is less than 0.75. There are other details that have been provided in the most recent guideline, that is 2016. Even though I did capture it, sorry about that. Now, in pseudo-normalization, EA ratio is greater than 0.75, but less than 1.5, and deceleration time is greater than 140 milliseconds. That's for pseudo-normalization. Then reversible restrictive, then we have for reversible restrictive diastolic dysfunction, that is stage 3. We will have that EA ratio is greater than 1.5. The deceleration time is less than 140. Then stage 4, which is fixed and restrictive pattern, we'll have the EA ratio is greater than 1.5 and deceleration time is less than 1.140 milliseconds. Now, going by that, the correct answer here is deceleration time is normal. Yes, deceleration time is normal, but so at least from the day-to-day equation, deceleration time is normal. EA ratio is normal. However, E prime over A prime is less than 1. So that is option A is correct here. Now, question number 8. I don't think anyone has any more to add to it. You can always let us know. Question number 8. Electrocardiographic changes in pericarditis typically passes through 4 stages. Each of these is stage 1. Concave up ST elevation and PR segment elevation. Concave up ST segment elevation and PR segment depression. Convex ST elevation and PR segment elevation. Convex up ST segment elevation and PR segment depression. Widespread T wave changes. Now, this is what I have here for stages of ECG changes in acute pericarditis. Stage 1, there is a widespread up concave ST segment elevation and PR segment depression with reciprocal changes in AVR, that is within the first 2 weeks. Now, stage 2 will be normalizing of the ST segment changes, the generalized T wave flattening. This occurs between 1 to 3 weeks. Now, stage 3, we have flattened T wave. The flattened T wave becomes inverted. This occurs beyond the 3 weeks. And stage 4, ECG returns to the normal shape. This occurs several weeks onwards. So with that in mind now, we'll recall now that the answer is B, where we have concave up ST segment elevation and PR segment depression. Thank you very much. Question number 9. Brain natriuretic peptide is influenced by all except.
Excuse me, sir.
Quite excuse, sir.
Can you hear me, sir?
I just heard the
Hello,
laughter,
Chief,
and
can you hear
nothing
me?
more. I just heard the laughter, sir. Only the laughter.
Oh, I think my network is horrible. It's frustrating at times.
Sorry
Okay,
about that, sir.
but yeah, thanks, sir. In pericarditis, acute pericarditis,
Yes, sir.
do you agree PR segment elevation cause?
Do I agree P segment?
Does PR segment elevation occur or it does not occur?
I didn't see anywhere where they say PR segment, there is PR segment elevation. What we rather have is PR segment depression.
What happened? Okay.
Hello?
What happens in AVR?
Okay.
Can you hear me?
Okay, correct. That's the reciprocal changes. Okay, thank you. Yes.
No, the thing is, your answer is correct. I believe your answer is correct. It's just that you commonly have more of the PR segment depression occurring across many leads compared to the changes, the PR elevation. You understand? It's a matter of which one occurs more commonly.
I didn't get it. Can you take it again, please? Sorry. Can you take it again?
No, can you hear me now?
Yes, sir. Yes, I can hear you, even though it's breaking.
So, okay, what I'm saying is that if I recollect, there is PR segment elevation occurring in AVR.
Yes, that's the
However,
reciprocal change they meant.
However,
Yes, sir.
what you will commonly find in acute pericarditis is the option that you chose. So it's about percentages. So the option you chose is right. Do you understand?
Okay.
PR segment elevation does occur, but you find that just in AVR compared to the PR segment depression that occurs across many leads.
Yeah.
Exactly. That's just what I wanted to draw our attention to. Thank you.
Okay, Chief Ajayi, one more thing.
Sorry, what occurs in V1?
One more thing, Chief Ajayi. Do we have PR segment elevation in any other lead other than AVR?
I
Yes,
don't
collect AVR and V1. You can have PR elevation.
What happens in V1?
The same thing that happens in AVR.
The reciprocal changes occurs in the two of them.
Okay, I wasn't sure of V1. But yes, I know that I've read a book that said that those changes that also happen, that PR elevation is quite it's a strong pointer to pericarditis. Those elevations. Yeah. Okay, fine. Thank you.
Thank you very much, Chief Ajayi.
Sorry, just to, hello?
Hello? Yeah.
Okay, I just want to be clear.
Your voice is distant, Chief Sawa. Your voice is distant.
Oh my. Sorry. How about now?
Wow.
Hello?
Hello, sir.
Yeah.
Hello? Is it better now?
Yes, it's better.
Okay. What I want to find out, are you trying to say that this change is an isolated change?
We can't hear you again.
Hello?
Sorry,
yes,
sir. It's like a pendulum. The audio is like a pendulum. It keeps going. Are you using what's it called? Earpiece?
Yeah, I'm using an earpiece, but I think the earpiece.
I suspect it is complicit in this eating. I think maybe you should try, if it's possible, to go without the earpiece. I don't know whether it might resolve it. Yeah, because we don't hear you once it's like every 2 seconds goes off.
No. Is this better now?
Yes,
if it remains like this.
Okay, fine. What I want to be clear is that these changes in AVR you're talking about, are you referring to them as an isolated change, isolated changes, or it occurs concurrently with this PR segment depression in other leads? Because my understanding is that predominantly what we have is the global PR segment depression, aside from AVR and V1, where we get to see what seems to be like the opposite of what occurs in those leads. That is my understanding. What you are trying to say is that these are isolated changes without the changes in those other leads. Thank you.
No, that's not what I meant.
That's not what,
because if you look at can you hear me, sir?
Yeah, I can loud and clear. I can hear you.
if you look at the ECG printouts of acute pericarditis, you'll find those changes occurring at the same time. You find what do you call it? PR depression across many, except AVR and V1, where you find the elevation. So they are occurring at about the same time. So
Okay.
I'm not trying to say that, yeah.
All right, yeah,
So they
because
do occur.
I think looking at their vector orientation, they are like opposite to the rest of the lead. So they are actually reciprocal changes that it reflects in them what we see in the other surface leads.
These reciprocal changes are like we have left bundle branch block, M pattern in the lateral leads 5 and 6, and then we are having W in the V1, V2 side. So it's just the same reciprocal changes that occur in left bundle branch block and right bundle branch block, where you have reciprocal changes in the if you're having ROSR in V1, V2, you're having reciprocal changes of W in V5, V6. So they are not actually the major clinical feature there is the PR segment depression.
Thank you very much.
Okay,
For the
let me also add that, for example, if we're looking at an ECG of acute, pericarditis, and sometimes it can look confusing when you're thinking of MI as well. So it's important to look at that AVR and possibly V1, because that can help us really acute pericarditis.
Distinguish it from
Myocardial infarction.
Okay. I don't know if I can also add my voice to the ongoing debate.
Yes, please.
On the floor of the
Okay,
house.
thank you. Okay, thank you. So, in case for people that need a code for this, although it looks straightforward, I use the code, pardon me, COFIN, that's COFIN. That CO means concave ST segment elevation, the F, the flattened T wave, and the returning the normalization of the ST segment, then the I inverted T wave, and the N normalization of the T wave. Then another thing to note is that you must always remember, as has been said, what AVR and V1 stand for in pericarditis. And like it has been presented earlier today, sporadic signs, yes, it tells us that there's acute pericarditis, but it's only in about 30% of cases. Then apart from MI, when we have benign early repolarization, we might be confused about to differentiate benign early repolarization from acute pericarditis. It's good that there's a formula that is used to calculate so that we are sure whether it's acute pericarditis or benign early repolarization, and this is best done using lead V6. And what is done is that the peak of R is measured to the I think that's the sloping of the S wave, and if it's greater than 0.2, no, sorry, the ST segment divided by the T wave. The ST segment, the I divided by the T wave, if it's greater than 0.25, it's more suggestive of acute pericarditis than benign early polarization that is same with LVH. Thank you very much.
Thank you.
Please
Thank
put
you,
up this thing for us.
Yes, can you please do that? Can you please write it down for us? Upload it on our WhatsApp blog.
Okay, I will do that, sir. Thank you, Chief Examiner.
Yes, because I can't even remember that ST segment to T wave ratio.
T wave ratio, yes.
It is greater than 25%. Implies which one? Is it pericarditis?
It's pericarditis. If it's greater than 25%, or if it's greater than 0.25, that is acute pericarditis. In the order it is
excellent.
Yeah,
okay,
thank you.
Great. Thank you so much. Thank you.
Thank you, Ade, and you tapping it on. Question number 9. Brain natriuretic peptide is influenced by all except, I think this one stands out. The cause of heart failure may not necessarily affect the I think the release of brain natriuretic peptide, whether it is from MI, or whether it is from hypertension, or whether it is from any reason at all. But it appears when there is heart failure. It does not necessarily indicate the cause of heart failure. Obesity causes a reduction in brain natriuretic peptides, and as well as brain natriuretic peptides increases with age. Then, of course, heart failure will cause an elevation in brain natriuretic peptides, as well as renal failure. Thank you very much. I don't know if there's any other addition before I move to the last question.
Sorry, I don't quite get this because
Question.
BNP is increasing heart failure, right?
Yes, sir.
So I don't really understand. I was
But
looking.
it doesn't, BNP does not suggest, does not indicate, does not state the cause of the heart failure. That's why A is the answer. The cause, the etiology of the heart failure.
Oh, thank you.
All right, sir. You're welcome, sir. Question number 10. The following is out of place as indication for termination of exercise test. All grades of chest pain. That's not true. Ataxia, because ataxia patient cannot do exercise testing. Ectopic atrial tachycardia, not decelerating heart rate, because we terminate that. And unsuspected appearance of VTAC, of course, we terminate because of that. I think the odd one out here is all grades of chest pain. Thank you very much. I think I will be able to upload even though that the indications are very wide, all other indications of termination of exercise stress test. ECG stress test later on the blog. Thank you very much.
So is there any grade of chest pain that would result in termination of EST?
Yes, of course. I think they say severe chest pain like that. Yes.
Any chest pain that the patient cannot cope with.
Yes, unbearable chest pain.
Unbearable chest pain. And what may be unbearable to you may not be the same thing with another person.
Yes.
Yeah, I think
Yeah,
apart from
angina.
the severity also, there's something about the progression of the chest pain. Once the patient is telling you that the pain is increasing in intensity, then at that point you definitely have to stop.
What is this one about unsuspected appearance of ventricular tachycardia? Prof's English at times, it can knock person engine. What is unsuspect? I've been looking at the statement, unsuspected appearance.
As if there is one we were suspecting. Well, as if there is a one we were expecting to come, and the unsuspected one appeared.
The unsuspected one is the one you don't get to arresting ECG.
However, I just interpreted it as appearance of VTAC, you know.
Exactly. That was the easiest way for me to make sense of it myself. That was just the way I could make sense of it. Thank you.
Thank you. Thank you, everybody.
Okay, I guess in the absence of any other debtor, I am likely going to be the next to present, isn't it? Hello? Hello?
Hello,
Yeah,
you're
For
audible,
this
sir.
mic.
I can hear you.
Am I audible? Hello?
Chief, we can hear you.
Okay, fine. I wasn't actually hearing a response, so I want to be sure my that earpiece is not messing up again. All right, so what I'm
Chief,
You're
that audio swinging has started again. Oh.
now. Wow. Hello? Can you hear me now?
Okay, it's better.
Yeah, much
Okay.
better.
And I didn't tell my village people that I'm supposed to be presenting today. All right, so question 16 of section C. It says, when ventricular tachycardia varies in stable but alternate complexes, it is described as A, paroxysmal, B, monomorphic, C, pleomorphic, D, torsades to pointes, and E, bidirectional. But I think what is important here for us to actually pick out is, one, there's a ventricular tachycardia, but it's the variation that we are talking about. So what we need to underline here is it is stable and alternating. So paroxysmal ventricular tachycardia does not alternate. Yes, it can, and it's actually not even stable. It just comes occasionally. Monomorphic does not alternate. Pleomorphic also does not alternate. In torsades to pointes, it does not, the alternation is not in sequences, but it's in bidirectional tachycardia that you see them alternating. You see one bit, the axis is going to be positive, the next bit is going to be negative. So I think that's what this question is talking about. So the answer here is E, bidirectional tachycardia. And one common cause of bidirectional tachycardia, they said, is digoxin toxicity. Whenever you see bidirectional tachycardia, I think digoxin toxicity should be key on our mind, especially if this patient is taking digoxin. I don't know if there's any more contribution.
Yes, Chief Tower.
CPVT too does cause the bidirectional.
Sorry, can you say that again?
CPVT.
Yeah, CPVT also causes bidirectional tachycardia. There's also one other very rare congenital disease that causes bidirectional tachycardia. It's called Anderson-Tawil syndrome. I don't know if anybody else come across that.
Move on then.
All right, thank you.
Sorry, before you move on, is that long QT syndrome? Or
The Anderson-Tawil syndrome?
Yes.
No, it's not long, it's not part of the long QT syndrome. It's a constellation of several other malformations that involve skeletal. It's actually a genetic disorder that involve some widening of the, I think, the trochanter, mongoloid eye species, low set ears, high palates, and bidirectional tachycardia is the key findings you get in the cardiovascular system.
Thank you so much. Please kindly help us put it on the group page. Thank you, sir.
Sorry, can you say that again?
I said we'll appreciate it if you help us put it on the group page.
Okay. I think I have, I had, there's one picture that summarizes all the features in Anderson-Tawil. I will drop that as soon as I finish this. Question 17, moving on. In the face of palpitations, carotid sinus massage can produce features that aid diagnosis. When it slows the heart rate gradually and the heart rate returns to the previous rate on discontinuation, which of these arrhythmias is suggested? This is hard nut to crack. Nevertheless, options A is sinus tachycardia, AV nodal reentry, C, AV reciprocating tachycardia, D, atrial flutter, E, atrial fibrillation. If we can recall, carotid sinus massage, what it actually does is that when you apply carotid sinus massage, it slows down the heart, particularly in tachycardias, when you want to actually make a diagnosis of if it's either an AV nodal reentry tachycardia you want to check. But the moment you do carotid sinus massage, it actually helps, and it will slow down the heart, and you are likely to see those P waves clearly, and it helps in your diagnosis. There are some publications I came across that in atrial flutter and atrial fibrillation, evidence has shown that in some instances, carotid sinus massage in predisposed patients who are actually predisposed, that can also trigger atrial fibrillation or atrial flutter. So in all this, the most likely answer is sinus tachycardia. But what I'm actually finding a little bit challenging here is that this issue of what it says that the heart rate returns to the previous rate on discontinuation. I think in all instances, except for atrial fibrillation and atrial flutter, the heart rate usually returns to its previous rate after you discontinue the carotid sinus massage. I might be wrong. I don't know. Any contributions, any clarifications here will be appreciated. Thank you. Hello?
I'm trying to check effect of carotid sinus massage on AVRT, AVNRT. We shouldn't just let go of this question like that. We need to find out what's the impact of carotid sinus massage on those
no doubt what it does in these two instances. If it is AVNRT and AVRT, it actually slows the heart down. In fact, it helps in making your ECGs to be much clearer, particularly when you are thinking, okay, is this an SVT? It is an SVT, quite sure about which one of it exactly. So at the moment you apply your carotid sinus massage, if it is those nodal dependent tachycardias, it's going to appear very clearly because it slows down the heart rate for you, and you now see the reading clearly. The thing is this: it returns back. The question says, and the heart rate returns to the previous rate on discontinuation. I think that is the most important thing we should be looking out for now, because I think they can also return back to the normal rate when you discontinue that, unless if whatever is the trigger of the arrhythmias has been eliminated. Anybody saying anything?
Hello?
Yeah, I can
Please,
hear
can you
you.
hear me? So, carotid sinus massage can be used to terminate most of these SVTs. It's used as some of the indications in your, like an accident and emergency, when you see a patient with an SVT. Ideally, the first thing you should do is a carotid sinus massage. It doesn't only expose the arrhythmia, it also helps you in termination. I know for AVNRT, it does it. In the second one too, in AV reciprocating tachycardia too, it does it. Even does it in some forms of atrial flutter. I can't put my neck out for atrial fibrillation because atrial fibrillation is no longer an SVT. But in some texts, they say it can help. But with sinus tachycardia, it doesn't have that same mechanism. So I know that it can help reduce sinus tachycardia, but it will go back to the same rhythm after, because it's not terminating it, because it's coming from the SA node. It will only reduce the heart rate, but it will not terminate it unlike the other ones, unlike the other 4. So actually, sinus tachycardia is a real thing because it will go back to the previous sinus tachycardia that the patient had before. It will not terminate the abnormal heart rate like it does in AVNRT and the other arrhythmias, because it can terminate actually arrhythmias, carotid sinus massage. That's the small information I have about it, according to the guidelines anyways. All right, thank you.
All right, thank you very much. I don't know if anybody has any more inputs. Otherwise, I will be moving on. Chief was okay.
Please go ahead, sir.
Okay, sir. Thank you. In which of these, question 18, in which of each...
Hello? Hello?
Okay, go ahead, ma'am. Go ahead, please.
I just checked this carotid sinus, carotid sinus massage. I think the answer is that's SVTO, because I'm reading an old Hurst textbook. That is the Hurst textbook. And it says that carotid sinus massage, that is used to differentiate that is used to differentiate sinus tachycardia from other, that is sinus tachycardia from other SVTs. And what happens is when you have sinus tachycardia and you do carotid sinus massage, it typically produces a gradual slowing followed by a gradual return to the baseline. Hello, can you hear me?
Yeah, we can hear you loud and clear. But what we want to be clear from what you're saying now is, which one are you describing? Sinus tachycardia or AVNRT or AVRT?
Sinus tachycardia.
Okay.
Sinus tachycardia. That's the feature you find in sinus tachycardia with carotid massage. You have a gradual slowing followed by gradual return to baseline. This is maybe an old edition of Hurst textbook. So maybe that is what he used to set the question.
Okay. What we want to be sure of is that in the AV node, for instance, if you have you do a carotid sinus massage and you make a diagnosis of AVNRT, after you discontinue your carotid sinus massage, does that terminate your AVNRT, or the heart rate will return back to continue what it was doing before you start your massage? Hello?
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 Where with you?
Okay, so can I continue?
Yes, sir.
Okay, question 18. In which of these is the likelihood of AF recurrence after cardioversion poor? A, chronic obstructive airway disease. B, congestive cardiac failure. C, mitral regurgitation. D, mitral stenosis. E, large left atrium. So essentially what this question I think is actually asking us is, if I understand the grammar, Prof has a way of twisting his own grammar. If you do, if in case there's if you get a patient in AF and you cardiovert, in which of these instances is the outcome of the cardioversion poor? That is the way I am looking at this question. I don't know if anybody has a different way of understanding this grammar. So I think the AFFIRM trial, if you look at the AFFIRM trial, in these two instances, mitral stenosis and enlarged left atrium actually have very poor outcomes in after cardioversion in atrial fibrillation. But that of mitral stenosis, yeah. So why mitral stenosis is chosen here, even when there's left atrium, is what I honestly don't understand. But I tried to look
because
up
I would
the
have also thought of large left atrium.
Exactly.
Except maybe probably because they didn't give the size, in that APAM study. Either they talked about greater than 4, is it 40 or thereabouts?
Yeah. Okay, so well, anyway, it's worthwhile for us to know that in this instance, the evidence base that we should actually rely upon is the AFFIRM trial, and the presence of mitral stenosis and enlarged left atrium actually have the instances where the outcomes of your cardioversion on the setting of AF is actually very poor.
But large left atrium comes above that mitral stenosis.
Mitral stenosis. So, but anyway, Prof. now in his own, he set the question and he answered it for us. He said it's mitral stenosis. So me, I don't cram my mitral stenosis. Answer. All right. Any more contributions?
Let's move on.
Yeah.
All right.
Okay. So
thank you.
I have a question. So this is Prince. I was wondering whether the large left atrium is, because we say large left atrium, what's the cutoff size? Because I understand that with the atrium, I mean, usually when it's usually in the range of 5.66 thereabout and above, that's when maybe the recurrence rate is very high. So if you say large left atrium, I think that may be the reason why the answer is mitral stenosis, because it's then difficult, because if someone has a left atrium of 4.1 centimeters, the risk of recurrence of atrial fibrillation is different from someone with a left atrium of 5.5 or 6.5 centimeters. I mean, that's my thought. I mean, based upon what we've read so far, because I just feel like it's a very wide area, large left atrium. So 4.1 centimeters. That's what I'm just thinking. It's just a thought.
Yeah, you're right. But it's instructive to note that Prof has answered it for us, which makes life easier. Okay, moving on. If there's no any other observations. Question 19. Electrical cardioversion is preferred to treat tachyarrhythmias, especially those resulting in hemodynamic perturbations. Which one of the following conditions makes a patient unfavorable to a positive outcome? A, symptomatic AF less than 12 months in duration. B, recurrent thromboembolic episodes. C, persistent AF after the trigger has been removed. D, consequent rapid ventricular rate that is difficult to contain. And E, if it results from sinus node dysfunction. So what this question is actually talking about is in which of these instances you likely to have an unfavorable outcome when you cardiovert a patient electrically. If you look at them, obviously, when there is a sinus node dysfunction, that is already a significant problem with the main generator. So even if you do an electrical cardioversion, as long as the sinus node is defective, I don't think you're going to get any positive outcome from that. So I think this is a straightforward question. Can we move on?
Hello? Yes, please.
Okay. Question 20. Significant rhythm disturbances could pass for normal in Holter monitored ECG.
Which of these is unlikely to be seen in normal patients on Holter monitoring? A, sinus bradycardia, B, sinoatrial exit block, C, wandering atrial pacemaker, D, type 1 second-degree heart block, and E, type 2 second-degree heart block. Essentially, what is asking is some of those arrhythmias that can be found in normal patients without any significant cardiovascular disease or any other consequences. In a normal person, you can see sinus bradycardia, you can see exit block, wandering atrial pacemaker, as well as type 1 second-degree AV block. But the moment you are seeing a type 2 second-degree AV block, you know that the heart is in trouble and it's liable to pack up at any time. So that is a red flag. The answer here makes it E. Straightforward. Any additions, any contributions?
What about option C, please?
Option C, wandering atrial pacemaker. Yes, I think that can also be found in some normal patients. And it might not be of any further consequences.
Patients be normal.
Sorry, hello?
Patients be normal.
Okay. Sorry, maybe I will have to rephrase. Individuals.
Thank you. Thank you. Next question, please.
All right, sir. 21. Cardiac dysrhythmias in connective tissue diseases is most likely to result from A, endocarditis, B, myocarditis, C, pericarditis, D, coronary artery thrombosis, E, autoimmune dysfunction. Connective tissue diseases, what those patients with connective tissue disease, what is most likely the mechanism of their cardiac arrhythmias? The answer they said here is B. I honestly could not find any reason why or why not the others. I don't know if anybody has any further clarification to this.
I think what comes to my mind, the conducting system of the heart is embedded in the myocardium. So therefore, if there is a connective tissue disorder affecting the myocardium, then it has potential to result in arrhythmias. That's the way I see it. We don't have conducting system in the endocardium or in the pericardium. It is actually in the myocardium. So diseases affecting the myocardium are likely to cause arrhythmia. That's the way I reason it.
Okay, thank you very much. Any more?
My hand is up here.
Okay, please, you can go ahead.
So the consequence of the myocarditis at the long term is myocardial fibrosis as a scar tissue, which is a substrate for reentrant mechanisms, so that can be responsible for dysrhythmias.
Okay, thank you very much. Any more? Otherwise, we'll move on.
Move on, please.
All right, question 22. Atrial fibrillation is the commonest arrhythmia in clinical practice. That's true. But the question is, which of the following is least accurate about it? A, found in 1% of patients older than 60. B, prevalence rises to more than 5% from 70 years of age. C, it occurs more in women than men. D, in sub-Saharan Africa, it is found mostly in the youth with rheumatic heart disease and the elderly with dilated cardiomyopathy. E. Occult thyrotoxicosis should be suspected in recent onset cases. Most of these answers here seems to be true apart from option C, where it says it occurs more in women than men. Based on the available literature, there's a slight male preponderance of prevalence of AF in men than women. However, I think that when I checked most of the literature, that difference is not statistically significant. It's almost equating itself. But if we look at maybe perhaps in subsequent studies, this trend might change to become more prevalent in women, maybe simply because of this established fact that we're beginning to have more of the elderly women population than men population. But presently, even the most recent AHA guidelines on management of atrial fibrillation, the prevalence of AF is more in men than women, even though it is very small and almost statistically insignificant. So the answer to this question is C, which is the false answer, obviously. Any contributions or questions? All right, in the absence of any, I'm moving on. Question 23. In atrial fibrillation, pulse deficit is a common finding because some contractions are unable to open the aortic valve. Hence, the pulse is irregular. When on occasion the pulse is regular, one of these should not be suspected. We all know that in AF, I always have irregular pulse. What this question is asking is that in the setting of AF and you begin to pick a regular pulse, one of these is definitely not happening in that instance. One, conversion to sinus rhythm. B, atrial tachycardia. C, atrial flutter with a constant ratio of conducted beats. D, development of junctional tachycardia, and E, development of ventricular fibrillation. So the answer here is E, obviously, because there is no how you're going to have a regular pulse in the setting of ventricular fibrillation. But in each of these other options from A to D, there seems to be some form of paroxysmal events, which it's possible that in one of those instances, you might be able to pick up a regular pulse. But definitely when there is a ventricular fibrillation, it's almost impossible. Even though they said you can never say never in medicine, but in this instance, I think the possibility is almost non-existent. So the answer to this question 23 is E. Straightforward, I guess. Any contribution or questions? All right, 24. Of the following, which is the most commonly recognized as a risk factor for the development of atrial flutter? A, hypothyroidism. B, alcohol binging. C, acute myocardial infarction. D, rapid weight loss. E, gradual weight loss. The answer here is alcoholic binge. If you look at in the gradation of the risk factors for development of atrial fibrillation and flutter, I think high among this list, even though they can actually cause, it can be a cause, but the highest among them is this B, which is alcoholic binge. Any addition? Straightforward too, I guess. Okay.
Rapid weight loss Will rapid weight loss result in any form of arrhythmia?
Very unlikely, I guess, but I don't know. Okay, moving on. Question 25. All the following characterize preventricular complexes except A, prevalence increases with age. B, occurs more commonly in males. C, related with low serum potassium and magnesium. D, occurs more frequently in morning after myocardial infarction episodes, even if there is severe left ventricular dysfunction. E, associated with chest pain. So I guess this question is talking about SVTs, and it's trying to characterize possibly what some of those things that can be related to SVTs. Prevalences can increase with age, yes, and most of the literatures I checked is actually relatively much more common in males, and it's related with low serum potassium and magnesium. Yes, patients with low serum potassium and magnesium are predisposed to development of arrhythmias, and they can have chest pain. So one of the odds one out there is option D, which says it occurs more frequently in the morning after myocardial infarction episodes, even if there is severe left ventricular dysfunction. So this is the odd one out among them. Option D is the answer for question 25. Any contributions?
Move on, please.
Okay, I guess that ends my part of the question. I don't know which second question 26. Okay, oh, I think they are no. Probably my last is 26. QRS wave contours may vary during episodes of ventricular tachycardia when it varies in a more or less repetitive manner. It is described as a uniform, polymorphic, torsade to the pointes, bidirectional, right to left bundle branch block pattern. So if we remember the earlier questions where what was described was alternating, stable alternating complexes of ventricular tachycardia. Here they are talking about the wave contours varying that vary with episodes of ventricular tachycardia. So this is just simply almost trying to describe the twisting axis of torsades de pointes. So the answer here is option C. In uniform tachycardia, you will not see the wave contours varying. In polymorphic, you don't see that variability like that. Likewise, in bidirectional, right to left bundle branch block, also you cannot see that kind of pattern. The most likely form where you see such kind of situations of variable contours is in torsade pointes. So the answer to this is C. That completes my section of the question, I guess. Thank you very much. Hello?
Yeah, we can hear you. Thank you very much, Chief Sawa. I don't know if Agro is on the call.
Okay, he's not around.
I can't seem to see him here.
If he's not around, we can continue because it's just a few minutes to.
I think my section, if Agu is not ready. I think I'm after Agu.
Yes, Alex, right?
Okay.
Yes, it will be.
Go ahead, sir.
Okay, what number are you taking, sir?
Section D, please.
Section D, 4 to 13.
Thank you.
Okay.
I don't think together.
Hello, can I go on?
Go ahead, sir.
Thank you. Good evening, teachers and seniors and other colleagues. Thank you for the opportunity to do this. So I'll start with question 4. Which of these lipid lowering agents has clear benefits on lipid and glucose profile? So all of these agents, they have effects, lipid lowering effects, from the bile acid sequestrants, ezetimibe, the fibrates, niacin, and statins. But one of them has effects on also lowering blood glucose levels. Just as a reminder, from the 2018 guideline, ACC AHA guideline, reducing the risk, the atherosclerotic cardiovascular disease burden through lipid management is one of the core recommendations. Then we can achieve that by use of any of the lipid lowering agents from the HNG-CoA reductase inhibitors like statins, cholesterol absorbing inhibitors, and then the fibric acid derivatives. Also by using bile acid sequestrants and nicotinic acid, and even the recent PCSK9 inhibitors. Now, to just help us recall or remember, ezetimibe, it selectively impairs cholesterol absorption, and it has a capacity to lower the LDL fraction, LDL cholesterol. While for the fibrates, the effect is in reducing triglycerides. The fibrates can actually reduce triglycerides by as high as 50%. And they also raise the HDL level, the high density. They raise HDL level by 5 to 20%. And that's why these fibrates are very, very effective in managing or treating patients with pancreatitis, because we know that hypertriglyceridemia is implicated in acute pancreatitis, so they help in rapid reduction of that. While niacin will also raise the high density cholesterol significantly, but usually niacin is given in combination with statins or with ezetimibe. So for statins, we know they are lipid lowering and they have a pleiotropic effect, in that apart from the fact that they lower lipids, they have capacity to stabilize plaques that are already formed, and then they are also anti-inflammatory. But when we come to the bile salts or the bile acid sequestrants, examples, cholestyramine, cholestyramine is also an example. They are used in primary hypercholesterolemia, and then they are usually used in combination, either with statins or nicotinic acid. Now, the effect they have is that they have capacity to raise HDL, which is the good cholesterol, lower LDL. At the same time, they also lower blood sugar levels, especially in type 2 diabetics. So back to the question now, which of these lipid lowering agent has clear benefits on lipids and glucose profile? The answer to this question will be, to this question will be A. The bile acid sequestrants have capacity to do that. I don't know if there are questions or comments to this before we move on. So the answer is A, bile acid sequestrants. Question 5.
Sorry, sir. I just wanted to add, sir. Hello, can you hear me?
Okay, please go on, sir.
Okay, yeah, I just wanted to add that in addition to the pleiotropic effects of statins that you mentioned, yes, plaque stabilization, anti-inflammatory, we should also bear in mind that they have anti-arrhythmic properties also. Then, what was the other thing that came to my mind? This issue of, yeah, well, up until the arrival of the PCSK9 and the, no, not the PCSK9. I know I read somewhere that of the lipid lowering medications, studies have shown that the statins hold a special role because, excuse me, they have demonstrated the most improved mortality benefits. That's what I wanted to add also. Thank you.
Thank you very much, Dr. Ajayi, for the addition. Okay, so the question 5 now, which of these is uncommon as side effects of excess exogenous corticosteroids? There are several effects from excess exogenous corticosteroids and a wide range actually of side effects with excess exogenous corticosteroid use, from ecchymosis to skin thinning and atrophy, presence of striae, acne, facial erythema. Excess exogenous corticosteroids can also impair wound healing. On the GI, they can cause gastritis, gastric ulcers, and can even precipitate GI bleeding. They also have effect on thinning hair. So the effects or the side effects from excess exogenous corticosteroid use is multiple. Like we know, the common Cushing syndrome can develop from excess exogenous corticosteroid use. And that is where you have things like central obesity, easy bruising of the skin, presence of striae. And the thing about excess exogenous corticosteroid is that it has profound CNS effect too, with a wide range of CNS pathologies, but notable amongst them is the ability to provoke or to cause profound depression in those who use them, especially prolonged use or an abrupt stoppage. Also, part of their side effect is that they can also cause hirsutism, which is actually development of hair growth in females, usually around where you normally have male hair pattern areas. But when you think about hirsutism, one of the key endocrine disorders one would think of will be things like polycystic ovarian syndrome, even though it can still occur in the setting of excess exogenous corticosteroid use. So, but the thing is that we're looking for the one that is uncommon, or let's say is less common to the others. Not as if it cannot be a side effect, this excess corticosteroid use, but it is least common in them. And so of all the options we have here, central obesity, depression, easy bruising because of how thin their skin is and the atrophy of the skin, hirsutism and striae, the one that is, we would say, uncommon in all this group would actually be hirsutism. So the answer to this is hirsutism, which is option D. Any additional question to this? Okay, now move on to 6.
Hello, house. Good evening, sir. Can you hear me?
Yes, please. Go on,
Okay.
sir.
Just to take us back, that question that had to do with atrial fibrillation and weight loss, I just saw something that said that significant weight loss actually reduces the risk of development of atrial fibrillation.
Okay, sir. Thank you.
Yeah, it's advantageous. Losing weight reduces the risk of the development of AF. Thank you.
Yeah, that's true.
Gradual or rapid?
It's part of the pillars.
Gradual weight
Weeks,
And
this thing.
in
Weight
the
loss.
answers of Prof, if obesity can cause weight loss, then if obesity can be a risk factor to AF, then weight loss should be protective. In the voice of Prof.
Right. Thank you. So let's move to 6 now. Which effect of thiazide-diuretic administration is least consequential when it comes to glucose control in hypertensive diabetics? This question really twisted my head. Chief Sawa, please, can you move it up a bit? Thank you. Thank you. Which effect of thiazide-diuretic administration is least consequential when it comes to glucose control in hypertensive diabetics? I'll need help here, but let me make an attempt first. Just an overview that thiazide diuretics, examples, hydrochlorothiazide, clothalidone, indapamide, metolazone. These are examples of thiazide diuretics. And we recall that they act on the distal tubules, and their action is brought about when they inhibit sodium chloride co-transporter at these distal tubules. What would that lead to? That would lead to increasing excretion of sodium and water, and that's how they induce diuresis. So in doing this, they can cause some form of, they have several side effects. Actually, it can cause hyperuricemia, hyperglycemia. It can cause electrolyte abnormalities like hyponatremia, hypokalemia, even hypercalcemia. Then they can lead to hyperuricemia as well, and then precipitate acute gout. That is why they have to be used with caution, actually. Then this drug can also cause some form of hypomagnesemia and other effects. I can't remember all now. And of course, they have effect on lipid profile too, so they can cause hyperlipidemia. So they can cause a wide range of metabolic and electrolyte derangement. So coming back to the question, we're looking at the effect of thiazide-diuretic administration is least consequential when it comes to glucose control in hypertensive diabetics. Now, the first option says action of renin-angiotensin-aldosterone system. By the time they cause diuresis, they can lead to some form of perception of renal hypoperfusion, which can stimulate or cause an increase in renin-angiotensin-aldosterone release. Then option B talks about diuresis. So their major effect is that they're going to cause some diuresis in patient, but the diuresis they cause is not as profound as what we have with use of loop diuretics. So we're still looking at the one when it comes to glucose control in hypertensive diabetics. So which of the options is least consequential? Now, when they cause hypokalemia can cause a decrease in insulin release. and can worsen peripheral resistance. So hypokalemia caused by thiazide diuretic administration can have profound effects in terms of glucose control in hypertensive diabetics. Same thing as hypomagnesemia. Hypomagnesemia has been implicated to also cause some form of poor glucose control. So all of this would have effect. So from hypokalemia, hypomagnesemia, and then the overdrive of sympathetic nervous system, which is actually what happens when there's some form of renal hypoperfusion and then activation of the RAS pathway that can cause some sympathetic nervous system overdrive, which can cause some transient hyperglycemia actually in the patients, or in the patients. So option A and E are somehow linked or tied together. And then there are clear links with how hypokalemia and hypomagnesemia would affect glucose control. But since they are
Rule out urinary tract infection.
Okay, rule out.
Rule out upper respiratory tract infection.
Hello, leader.
Very poorly treated malaria.
Leader, sir. So the likely option here is the diuresis. And that was the option picked, but this was a tough question to look at. I don't know if there are additions or further clarification to this. Thank you.
Me, I don't understand how you implicated this overdrive of the sympathetic nervous system.
It's from what I read, it's related to the renal hypoperfusion that occurs seemingly as a result of the diuresis caused by the thiazide diuretics. So this seeming perception of hypoperfusion will stimulate the RAS pathway. And one of the effects is that there can be an overdrive of the sympathetic nervous system in trying to restore back homeostasis. So that has some implication as well as in terms of glucose control.
Okay, I get it. Thank you, sir.
Yes. So but it's not a very straightforward question really. But for option C and D, it's very clear how they're able to affect glucose control. And then the least one looks like diuresis, even though one can argue that the diuresis can cause dehydration, and dehydration can also cause some form of hyperglycemia or affects glucose control as well. But that's the option that Prof picked. Thank you, sir. I don't know if there's any other comments. Okay, question 7 now. In which of these sites is the digoxin effect the least? That's which tissue is the effect of the digoxin felt least? Is it in the atrial tissue, atrioventricular node, SA node, or ventricular tissue? We've seen quite some questions on the digoxin, but the effect of the digoxin is felt less actually in the ventricular tissue. I think that's pretty straightforward. Can we go to 8? Thank you. 8 says, in which of these tissues does the digoxin effect manifest its electrophysiologic action by a negative dromotrophic effect? Is it in the atrium, the AV node? I think there are more options.
The disconnected bridge here.
But the thing is, the toxin has a negative chromotrophic effect on the AV node, and that leads to an increase in refractory periods and nodal conduction time. And that is how it actually reduces the chromotrophic effect. So when we talk about dromotrophy or a dromotrophic agent, a dromotrophic agent is one that affects the conduction. It affects conduction speed in the AV node. And because it's affecting the conduction speed, it will subsequently have an effect on the rate of electrical impulses in the heart. Okay, so the effect of the digoxin is actually a negative dromotrophy. But when you talk about molecules like epinephrine now, epinephrine actually has a positive dromotrophic effect. So a dromotropic agent is just one that affects conduction speed. So the affectation of conduction speed could be negative or positive. So digoxin has a negative dromotrophic effect, while things like epinephrine stimulation has a positive dromotrophic effect. And then another thing that has a negative dromotrophic effect is when you have vagal stimulation. Okay, and that's actually a likelihood of the pathway through which digoxin manifests its electrophysiologic action. So I think maybe there are more options to this, but the answer is already displayed. It's actually the AV node. Thank you. These are the questions that had many gargagia. How about medications? Okay, so it says, which of these agents would impair antihypertensive response of thiazide diuretics when given together? Which of these agents will impair antihypertensive response of thiazide diuretics when given together? Most of these options here, Ascara, ginkgo biloba, licorice, senna, they are all alternative medicine or more of herbal medicines, but somehow some have been encapsulated, like ginkgo biloba, which a lot is used in terms of in stroke patients. A number of people do use some of these medications. But the thing about them is that some of them should not actually be taken with thiazide diuretics, like the licorice. Licorice on its own would cause some hypokalemia. We know that thiazide diuretics cause hypokalemia. So if you give them together with thiazide diuretics, it will potentiate the hypokalemia that can be seen in them. The cascara is an anthrapylose glycoside. Okay, and then it also has a potassium depleting effect. The major use of this cascara, which the stem, that's the middle part of it, is what most people use. But the major effect is that it is known for its laxative effect. That's the major thing that is known about the cascara. It has laxative effect. Then the licorice is actually a plant root, a very ancient plant root. And then it is used by some people for digestive issues, those who have heartburn, and some people even use it for dyspepsia generally. While the horsetail concoction is used for different types of treatment. Some say they use it for to stop bleeding, to heal ulcers, to heal wounds. And then senna is also a plant that is used for the treatment of jaundice, typhoid. And so all these options, they're actually non-orthodox kind of treatment or medicines that have a varied effect But when I looked through the literature, the only one I found that together with Mikaya said licorice is also used as food flavoring for sweets and other confectionaries. Thank you. But in the options, the one I found because most of them, what you read about is their potentiating effect that they can have with thiazide diuretics and further worsen hypokalemia. So they are not advised to be taken with them. But the one that has an association impairing or worsening blood pressure control is actually using ginkgo biloba with thiazide diuretic. So which makes question 9 to be option B, use of ginkgo biloba.
Sorry, I thought I've read somewhere before that licorice too increases BP. I think there's something about it and blood pressure. Then this senna is what they use in most of these slimming teas to purge people and make them shed water with.
Is what they use?
Slimming teas.
Yes.
They use it a lot in slimming teas because it's also a laxative. Then I know I've seen something about option D and BP. I'm not too sure again, but I think that it increases BP.
But
I'll search it.
I didn't see that. Maybe I'll check more, but
Okay.
I not clearly
I'll
with
check. Okay.
Thank you. Please, are there more comments? Thank you, Chief Sawa. Can we move to 10? And reads, in sequential blockage of sodium reabsorption, metholazone works when so in sequential, generally in practice, when patients have limited response, either to, for example, a patient was on 60 milligram IV of furosemide, then you are increasing to 120 or to 80 as bolus or as continuous infusion, when there's limited or poor response, okay, and then you have increased the dose, you would want to consider another diuretic that will have an additive effect that will help with the diuresis. And that's where the thiazide diuretics easily come in. And we recall that metolazone is also a thiazide diuretic, and they're talking about sequential nephron blockade. They are looking at, the thiazide, metolazone will act on the distal convoluted tubule, and it will actually block the sodium chloride channel, the DCT. Okay. And then in that way, when they do that blockage, they will now, reduce the sodium absorption. They reduce sodium absorption. So what happens in sequential blockade of sodium reabsorption is that administration of a thiazide diuretic like metolazone, some physicians have said like 30 minutes to 1 hour before the dosing of a loop diuretic, is to ensure that the distal sodium chloride channel is already, the distal sodium chloride channel is already blocked. Sorry, I was saying some chats, but I'll come back to it. Oh, thank you, Alabi. Licorice can cause dangerously high blood pressure and hypokalemia. Okay, thank you.
I'm just seeing one article now that is a root cause of secondary hypertension in people that consume large amounts of it.
Oh, thank you. So you can see that question because ginkgo biloba too is associated. So the answer to that question now. So, but let's just, Prof said it's ginkgo biloba B. So I think we'll stick to it.
Okay, sorry, hello? I thought in that question, making a direct reference to thiazide diuretics.
Yes, sir.
Okay, so will that still confound the answer? Because does licorice cause elevated blood pressure through impairment of either metabolism or action of thiazide diuretics?
Christy, did you
I was
check it
thinking
with thiazide? Just straightforward.
Okay, no. No,
because
I'm
if you
just
look at
adding that time. Now see what I'm seeing here. They said it causes pseudo-aldosteronism with sodium retention and potassium loss with edema and increased blood pressure. So it increases aldosterone. So it does not, which of these agents will impair antihypertensive response to thiazides when given together? Okay, so it shouldn't be, because Adibi maybe they said spironolactone, then we can say yes, because it's going to, as spironolactone is trying to block aldosterone, it will be increasing aldosterone. So it will be like, it will counter the effect of aldosterone. But this is thiazide.
Yeah, it's making specific reference to thiazides and when they are given together.
When they are given together, okay, so it's licorice and aldosterone antagonists.
So since there's this clause of giving together, I would want to guess perhaps maybe it has to interfere with the absorption or something.
Okay,
I don't know.
it's possible.
Yeah, but if you look at the literature, actually, for thiazide diuretics, there's a clear link with ginkgo biloba in terms of it.
Okay.
And I checked that with licorice. I didn't see that. There was no, that's together with thiazide diuretics. Of all of them is the ginkgo biloba.
Okay.
Okay.
Thank you. This question 10, talking about sequential blockade of sodium reabsorption. So in sequential nephron blockage, it consists of a progressive increase in sodium depletion using a thiazide diuretic. You can also use an aldosterone receptor blocker or a loop diuretic. So it's just sequential. As much as possible, it consists of progressive increase in sodium, just one more and more sodium depletion. Then in literature, what I saw, most physicians would prefer to use metolazone in this case, and they would rather prefer that it's given 30 minutes or 1 hour prior to use of a loop diuretic. So that gives us option B as the answer. It's not given after, but it's given before, 30 minutes to 1 hour before, just to help with sequential blockade and increase sodium depletion. And first, to use a thiazide diuretic, you can use an aldosterone receptor blocker, and then use a loop diuretic. Then you can even use amylorate at the end. So the answer to 10 is B.
Okay, and I also think the reason why thiazides are given before loop diuretic is because of their duration of action. Because thiazide loop diuretics, their half-life. Okay, not all, but like for example, furosemide is like 6 to 8 hours. But most of these thiazide diuretics, they are like 24 hours. So by the time you give them earlier, they tend to go and block the distal tubules, then before you give the loop diuretic, so that even when the loop diuretics, the effect has gone, those ones will still stop it. But if you look at it in the other way, if you give loop diuretics first before you give thiazide, some of the sodium can get to the distal convoluted tubules and they will be reabsorbed. That's before, if you don't give the thiazides first.
To block here. Thank you, Coach Alami. Any more comments? All right, so let's move to 11. Diuretic resistance in heart failure can be combated by all what? Diuretic resistance in heart failure can be combated by all but A, avoidance of NSAIDs, that should be NSAIDs, I think. B, permitting dietary salt, add libitum. Restriction of dietary salt, sequential blockade of sodium reabsorption, use of potent vasodilators. So we're looking at the diuretic resistance in heart failure can be combated by all. So if you look at the other options, A, avoidance of NSAID, restriction of dietary salt, sequential blockade, use of potent vasodilators. These are ways in which we can, reduce diuretic resistance in heart failure. But if you look at option B, which talks about permitting dietary salt, add libitum. Add libitum simply means as much as one prefers, one desires, or as much as is necessary. In these patients, you would, as much as possible, want to restrict, do a dietary salt intake restriction, which is part of their management. So reducing sodium load in them. So the option that is off, that is not used to combat diuretic resistance, is actually option B, which is talking about permitting salts libitum as a person desires. So I think that's quite straightforward. 12. Gingivitis does not occur with this. So I'm looking for one of the options that will not cause gingivitis. And for this question, I think I had a challenge because, well, the major causes of gingivitis are anticonvulsants, the spectrum of anticonvulsants, calcium channel blockers, immunosuppressants that will cause gingivitis, anticoagulants as well, and then even use of heavy metals, use and injection of heavy metals like lead, bismuth, all this can cause gingivitis. And I even found surprisingly that oral contraceptive pills too can cause this. So if you look at anticoagulants, yes, they can cause gingivitis, calcium channel blockers, fibrinolytic agents, OCPs, they can all cause gingivitis, and even heavy metals. But from the book, Prof chose lead compounds, even though I saw that lead and some heavy metals have been implicated causing gingivitis. So I'm really not sure, but the answer in the book is option D. So I wouldn't know whether there are comments to this. We'll just take the last question. All right, last question for me, question 13. Which of these does not fit into the list of factors limiting use of amiodarone? In other words, we are talking about the side effects or what would prevent us using amiodarone. A, corneal deposits. Yes, we know that amiodarone can cause corneal deposits. Hypertension, pulmonary toxicity is associated with it. skin changes, thyrotoxicosis because of the iodine load. So if you look at A, C, D, and E, they're all associated with use of amiodarone, and they can limit its use, but not hypertension. So which makes the answer to 13B. I don't know if there's any question or comments. Otherwise, that wraps up my section. Thank you.
Thank you very much.
Dr. Itubi,
Yes, ma'am.
I just brought something now, but I saw that, yes, lead can cause gingivitis in some occasions, but most times it causes gingival pigmentation. That's the commonest finding you find, but they can cause gingivitis in rare cases. But the commonest thing you find is gingival pigmentation.
Excellent. Thank you.
So maybe that's why he picked that. But they cause gingivitis, but the commonest finding is gingival pigmentation.
Pigmentation. Okay. Thank you very much. Thank you, everyone. Class rep, over to you.
Next presenter, please.
Okay, are we going on? Okay.
Or do we stop here?
Chief examiner, you don't want us to hear your stuff tonight?
It depends on how many of us that are awake.
Well, this is 28 people, but we don't know how many people are awake. People can just be
Dr.
connected and not.
I thought you've been sleeping since.
I've been listening to your sweet voice. Look who
Let me hear. All of you kept quiet now.
We are here. So, Chief Examiner, we are here.
Let's go on and see if we can finish mine this night, and then.
Thank you, sir.
Yeah, I'm continuing from number 14 to 23. Number 14 says lifestyle adjustments necessary to maximize benefits and minimize risk of warfarin therapy include all but one of the options here. And we have alcohol avoidance, avoidance of potential traumatic situations, avoidance of contact sports, frequent INR monitoring, and high vegetable diet. Of course, if we are on warfarin, it is advisable patient avoid alcohol because of the impairs the liver, and that could also enhance the warfarin toxicity. It also impairs platelet aggregation. The same thing, of course, B option, contact sports because of the risk of bleeding. You remember that warfarin requires constant, frequent monitoring, and at each point in time, you can't guarantee what the INR will be. So it's possible that contact sports and traumatic situations can lead to prolonged bleeding, which may not be good for the patient. For option E, high vegetable diets. Of course, most of the leafy vegetables we know they're rich in vitamin K. That wouldn't also be good for patients that is on warfarin. So the right option there is E, the high vegetable diet. Once a vegetable is taken, high vegetable diet is taking a lot of vitamin K, and then that will affect the warfarin functions and warfarin activity. So the right option here is A. Now, question 15. Arterial saturation persisting after administration of 100% oxygen suggests A, cardiogenic shock, B, overdose of pre-medication, C, pulmonary disease, D, pulmonary venous congestion, E, right to left shunt. Option A, B, C, and D go in common that once we give these patients 100% oxygen, we increase the oxygen contents of the blood and the tissues, and that definitely allows saturation of such patients to recover. But in right to left shunts, you will be giving oxygen, and then at the same time also, what's the action and that reaction becoming equal and opposite, because the more you are giving these patients oxygen, the more deoxygenated blood flows from the right to the left side of the body, bypasses the lungs and mixed with the oxygen you are giving to, and mixed with the oxygen in the blood of the patient, and that would also be bringing down the arterial oxygen saturation. So in these situations A to D, oxygen therapy alone can do that, but in E, in treating such a patient, you require a more invasive procedure to sustain oxygen saturation for such patients. So the right option here is E, right to left shunt. In right to left shunt, arterial desaturation persists after administration of 100% oxygen. Question 16. In which of these situations does positive ionotropism and digitalis toxicity occur? We've had a lot of discussions both from our brown watch, digoxin use, and then digoxin toxicity. I'm sure Prof will likely bring out that question. Bring that question back in the theory session. It was one of the questions he asked in the theory question. About three of them, what underpins the use of digoxin, and then the other one asked about digoxin toxicity and the rest of it. So, going from the common ones we see with patients, clinically the patients come down with weakness, come down with nausea, come down with vomiting, and then to the ECG changes and to some of the other changes that have been mentioned here before. Those both the ones that can occur in the eyes and the rest of it. So you now find out that option A for a normal heart, right, only is not the right option, because both ionotropism, where the main action of the digoxin directly acting on the cardiac muscles through the membrane to effect its ionotropic effects works. It also works on B, the failing heart. So the correct option here is both normal and failing heart. The ionotropism and digitalis toxicity occur in the two of them. So it's not just only in normal hearts, not just only in failing heart, but both normal and failing hearts we experience both ionotropism and digitalis toxicity. So question 17. Question 17.
Sorry, please. So what's the answer?
What's left of? So the answer here is C, in which and digitally they have.
Thank you.
So as assuming I am normal. I don't have hypertension. I don't have diabetes, and I'm taking digoxin. Both inotropism will occur at the initial stage, and then as the dose intolerance stage, the digitalis toxicity will begin to occur. So it occurs both in normal heart and then in failing heart. That's just what Prof tries to bring out here. Question 17. Which of these brings about positive inotropic action of digitalis? A, activation of sympathetic nervous system. B, atrioventricular block. C, direct effects on cardiac contractility. D, increased catecholamine sensitivity. E, vagal inhibition. Well, I tried to look up these. First of all, digoxin works by inhibiting the sodium potassium ATPase form, thereby which is at the cellular membrane of the cardiac tissue, which increases the intracellular calcium, and then, of course, invariably increase the force of contraction. Then there is also a parasympathetic stimulation of digoxin, which causes the bradycardia. The parasympathetic stimulation of the autonomic nervous system that leads to bradycardia. Then we also have the catecholamine effects. In that catecholamine effects, we have a catecholamine reuptake at the nerve terminal, and then that would also increase the sensitivity to catecholamines. So of all mentioned now, activation of sympathetic nervous system, no. What we have is parasympathetic stimulation. Atrioventricular block, which brings about the point. Of course, atrioventricular block is not the inotropic action, even though it can be part of the digoxin effect, but it's not the inotropic effect. Even the increased catecholamine sensitivity is not also the inotropic effect. So the correct answer for 17 is direct effects on cardiac contractility through inhibition of the sodium potassium ATPase form that increases the intracellular calcium and increases the force of contraction. So the correct answer here is C. Not E. E is not inotropic, which is vagal inhibition, and not D, increased catecholamine sensitivity. Question number 18. Where is the site of digitalis action in the heart located? I mentioned this while we are talking of question 17, and the answer is already staring at us is not at the mitochondria, is not at the myocardial fibers, is not at the nucleus, is at the plasma membrane, as I mentioned while we're discussing the background to question 17. Then it's not a cytoplasmic reticulum. The answer is D, the plasma membrane. Question 19. Use of nitrates in acute heart failure is most commonly by, we came across this in Brownwald. What the good thing Brownwald does is to give us a very big background. Nitrate is used in acute heart failure to rapidly reduce preload and afterload. Of course, it causes venous dilatation and then arterial dilatation, thereby increasing cardiac workload and then increase the cardiac output. Now, if we want to guarantee a quick response and then exercise good control of the effect of this nitrate within this acute management of heart failure, it makes sense, therefore, that the best route to give nitrates in acute heart failure is through the intravenous route. So sublingual routes will not be appropriate, oral route will not be appropriate, transdermal route will not be, inhalational route will not be appropriate, because we want to guarantee a quick and precise control of the effect of high nitrates in managing heart failure, managing acute heart failure. So the correct answer here is D, the intravenous route is the route of choice of administration of nitrate in acute heart failure. Question 20. Which of these is not an advantage of the novel oral anticoagulants over vitamin K anticoagulants? A, less intracranial bleeding. Remember that we are looking for the option that is not an advantage of the NOACs over the VK anticoagulants. So less intracranial bleeding, it is an advantage. It has a less intracranial bleeding. Consistent results, notwithstanding time in therapeutic range. Consistent result, notwithstanding time in therapeutic range. Well, let's take a look at the background of that time in therapeutic range, which is the percentage of time with INR within the target therapeutic range. When you look at the time in therapeutic range, we are looking at that aggregate percentage of the aggregate time within which the INR of that patient is within the therapeutic targets for that INR. So you now, for warfarin, you require a higher time in therapeutic range to sustain its effect. So what is trying to explain here is that with warfarin, and then this person has taken it over a week, you require a higher percentage, you know, for warfarin, taking 24 hours times 7 days, which means like you need this patient to maintain this therapeutic range for about 6 days of that 7 days for it to sustain its effect. So that now takes out that one, because with the novel oral anticoagulants, you don't need this time in therapeutic range. It guarantees that consistent results, notwithstanding any time in therapeutic range. Laboratory monitoring is not mandatory. Yeah, of course, we don't need to monitor like we do with warfarin. Less drug interaction. Yes, less drug interaction than warfarin. Then more drug food interaction. That's the wrong option. It's warfarin that has a more drug food interaction. So which of these is not an advantage of NOACs over vitamin K? More drug food interaction. The rest of the options are advantages of NOAC over VKA. So the correct option here is E for question 20. The answer is E, more drug food interaction. So let's go to 21. Question 21. Switch from VKA to NOAC anticoagulants is desirable if creatinine clearance is less than 30 ml per minute. Creatinine clearance is greater than 95 ml per minute. Patients are wearing prosthetic valves. Cost constraint is an issue. Patient has atrial fibrillation and only on single antithrombotic therapy? I must confess that I tried checking the background of this question and I couldn't come up with any reasonable answer or any search to explain it or to understand this. Completely, I didn't understand this and I had to take whole and sinker what Prof gave as the answer, which is E. Patient has atrial fibrillation and only on single antithrombotic therapy. So switching from VKA to anticoagulation is desirable if patient has atrial fibrillation and then only on single antithrombotic therapy. Even that answer, only on single antithrombotic therapy. If anyone understands it better, probably we may need to hear from the person. Otherwise, we just grab it and move to 22. Do we have any clearer explanation for code 21? Or do we move to 22? Hello? Hello? Are we sleeping?
We are here.
Okay. Question 22. One of these visual symptoms does not suggest digoxin toxicity. Red vision, snowy vision, photophobia, they're all part of the eye manifestations of digoxin toxicity. Photopsia, which is a perception of flashes of light, is also part of the manifestation. So A, B, C, D are all correct answers. We are left with E, a persistent scotomata. Is not recorded as one of the eye effects of digoxin toxicity, which is a blind spot on vision. So the correct answer here is E, persistent scotomata.
Sorry, sir. I thought it's more of a yellow vision it gives. I don't understand.
Which one?
Digoxin toxicity.
Is it
it's more of yellow.
That's the same thing I was thinking. Shivis, they say yellow green.
Yes.
I was wondering how red entered the thing.
Autopsias.
Yes, yellow green halos. I think something like that.
No, Dr. Sarah, you are cycling not. Yes, we agree. But even red's supposed to be not too, because we don't know red as part of the color issues.
I think I searched for this. I didn't see clear explanation. So it's one of the questions again that we go with Prof. But definitely, persistent scotomata is not. It doesn't give it at all. So any other thing that has to do with blurring of vision, snowy photophobia, photopsia, we can actually go with them. But of all the options, the last option, scotomata, it doesn't give it
Well, for some of us that are hello. For some of us that are colorblind, that cannot really differentiate. Sometimes yellow can be looking like red for us.
And green can look like white.
All men are guilty of this. They don't know colors.
Oh God. Chief, sir, I want to ask, is it the persistence that is making this option not suggestive, or we can also see scotomata with digoxin toxicity? Do you understand my question, sir?
Yes.
Thank you, sir.
Is the scotomata? That persistent was added to make it look like it doesn't cause to matter at all.
Oh, all right, sir. Thank you, sir.
Okay, let's take the last question for my own session, 23. In the treatment of hyperuricemia, which of these drugs operates by inhibiting the urate transporter 1? A, allopurinol, that is antinoxidase inhibitor. So, B, the topirostat, that's also a xanthine oxidase inhibitor. C, the benzbromarone, that's urate transporter 1 inhibitor from my search. But let's look at D, zozazolamine is a central acting agent, skeletal muscle relaxant. Actually, it has nothing to do with treatment of hyperuricemia. Zozazolamine is a central acting skeletal muscle relaxant. And then the RAS buricase is an enzyme, enzymatic agent that converts uric acid to allantoin, which is the soluble and excretable form. So of all the options, the option E, zasburicase, converts uric acid, because the question can come in a different form. Converts uric acid, the Prof can ask which of these agents converts uric acid to allantoin. So in this instance, now E will be the right answer. So E is also used in management of hyperuricemia, but it converts uric acid to allantoin. But for 23, the correct answer is C, the benzbromarone, which is an urate transporter 1 inhibitor. So of all these, A and B are xanthine oxidase inhibitor, allopurinol and topirostat. They are xanthine oxidase inhibitor. So the answer here is C, benzbromarone. Thank you. I think I'm done with my own session.
Thank you so much, Chief Examiner. Chief Uzoke, please, are you there? Okay, it's not. It's 3 minutes to 12. So, Chief, sir, should we continue or should we go and rest tonight? It's whatever we agree on.
We need to reserve some energy against tomorrow.
Oh, I agree with you, sir. But let's hear from other people too. Are we sleeping?
Leader has
Looks-
spoken.
The leader have spoken. Okay. Okay, I will just quickly make a brief announcement. One of us was really, really magnanimous, and as a way of trying to recollect everything that we've done tonight, there is a time quiz. That means the quiz is timed on the Telegram page that we can quickly use to see and recollect what we've done tonight. So we can read it as many times as possible. This is courtesy one of us. Thank you so much, everyone.
Thank you.
All right, thank you everyone for a very, very exciting time. Today, I really, really enjoy a lot of the presentation. Thank you, Dr. Danya. I understood that you were not feeling fine. I think she has left for taking the acute pericarditis. Dr. Ayodeji Stephen and Dr. Florence. Dr. Ayodeji Stephen was supposed to take cyanotic heart disease, and Dr. Florence is cyanotic. I think there was a mix-up in the timetable. So Dr. Florence already prepared for cyanotic. So I told her that since she took a cyanotic before, she can go ahead and present it. Why Dr. Ayodeji, who reached out to me earlier to present the congenital heart disease he did in, I think, last year. So I don't know. Ayodeji, are you there? Ayodeji.
Hello? Yeah, I'm here.
All right. Good day, brother. So I think you did cyanotic heart diseases, right?
Cyanotic.
Okay. So in that timetable, you may have to take yours before Florence, isn't it?
No, it's after.
Okay, after her. Okay, so she will take her usual cyanotic that she cyanotic that she did before. Okay, so that you can.
Cyanotic you did before.
Okay. So she will do the cyanotic. Good enough. She already also prepared slides for cyanotic. She sent it to me, very detailed too. So, but I still told her to keep up with the previous presentation. She was supposed to take the cyanotic she prepared, the cyanotic that she took the first time, so that you can take yours. So, so probably tomorrow she will take it.
Sorry, can we stop this recording?
Is that what?
The recording is still on.
Wait, sorry, Wednesday I'll take mine.
You take yours on Wednesday. She'll take hers today or tomorrow. We are already in Tuesday now, so she'll take hers.
I was thinking if it's more appropriate to stop the recording while we discuss.
Okay, I don't know if Kweki is there. Maybe the recording is just on. Kweki, are you there? I think the recording is just ongoing. All right, so that's very great. Thank you so much, everyone. God bless. I think tomorrow we'll start again. Very good commitment to stay till 1 a.m. 12 midnight. Thank you, everyone. Thank you, Dr. Sarah, for your part. Very excellent. Thank you, everyone. Thank you specifically and especially our past NAD president and our chief, our boss, Chief Dr. Onyebweze John Ogochukwu. God bless you, sir. You're always an elder, very supportive. Thank you, sir.
Thank you. God bless you too.
Thank you very, very much. All right, bro. Thank you. Kweki, are you there? All right, so guys, see you tomorrow. Thank you.
Yes, sir. Thank you, sir. Good morning, everyone.